Good morning, everybody. Thank you all for joining us. I just wanted to let you know that those of us who are gathered physically in the room are getting settled in, and we're going to give everyone a few more moments to join us online, but we'll get started in just a few minutes. Thank you.
Good morning, everyone. I happily call together the Virginia Department Board of Health meeting for September the 2nd. And let me first just go over a few of the details of our meeting. This meeting is being conducted in a hybrid environment and is being recorded. And there are several things that we would like to review before we get started. At this point, we do not have visitors in the room, but should we, I would ask that everyone maintain appropriate decorum. No talking, no unnecessary noises. That applies to us, too, right? During or inappropriate comments, in other words, please be polite and respectful towards others at all times while in this meeting, and this will also enable the board members to concentrate and focus on all of the information and comments that are provided during the meeting and to be able to clearly hear what each speaker is saying. For today, the names of all board members, along with the constituency that they represent, are displayed on the screen. Several board members are participating virtually. Their names are Linda Hines from the Managed Care Insurance Plans. I feel like I should let you guys do this yourself. Linda, you want to introduce yourself, and then we'll go this way around. Good morning. I'm Linda Hines. I'm representing the managed care industry.
Good morning. I'm Jim Schuler, and I represent the Virginia Veterinary Medical Association.
Good morning. I'm Benita Miller, and I represent the Virginia Dental Association. Good morning. Holly Puritz, OBGYN, representing Medical Society of Virginia.
Hi, I'm Jim Edmondson from Fairfax County. I represent corporate purchasers of healthcare.
And I'm Faye Pritchard. I represent local government. Those are the members in physical attendance. Alex, do we have the ability to let our board members who are online introduce themselves? We absolutely do, Madam Chair. They can go ahead and unmute themselves if you want to call out their names, and then they can unmute themselves, or I can do a roll call if you prefer. You don't mind doing the roll call because it's a little bit hard for me to see from here who's in what order. So those of you who are online, Alex will call your name, and you just introduce yourself and the constituency you represent. Mr. Kreitzer?
Yes, Gary Kreitzer, representing Emergency Medical Services.
Thank you. I believe Mr. East is not able to join us today. The next virtual member is Ms. Harrison.
Hi, it's Lisa Harrison, and I'm a consumer member of the board.
Thank you. Dr. Jane?
Dr. Jane represents Public Environment Health.
Thank you. Dr. Kinzer?
Hi, I'm here representing the Voice of Nursing.
I think I was on mute. I'm Catherine Waddell. I'm here representing the consumers.
Thank you. Dr. Klein?
Hi, this is Dr. Wendy Klein, representing the Medical Society of Virginia.
Thank you. Dr. Swartz?
Hi, good morning. Stacy Swartz, representing the Virginia Pharmacists Association.
Thank you. We heard Ms. Waddell. Ms. Whipple?
I am Mary Margaret Whipple, representing the hospital industry.
Thank you. I am getting a few comments. I do want to let everyone know that my screen is fully visible to everyone in the room. So if you need technical assistance, please privately chat John Ringer, and we will do our best to assist you. We are aware that there is some static that may come and go from the boardroom. It's a speaker issue here, and there isn't a whole lot we can do, but we will do our best to mitigate that. All right, have we got everybody? I'm going to depart from our normal agenda for 2 seconds here this morning to congratulate Dr. Kinzer, who's been promoted to full professor of nursing at VCU this past week, and we are very proud of her. All righty. In addition to our board members, there are several staff members from the Virginia Department of Health and the Office of the Attorney General who are physically assembled at the Perimeter Center in Henrico for this meeting. Consistent with public health recommendations, they will be wearing face coverings and sitting 6 feet apart. This is also true of our board members. The list of all staff participating in this meeting is displayed on the screen. Some are participating virtually. Lastly, all votes that are taken by the board during today's meeting will be roll call votes. I will be restating the name of the members who make the motions or the seconds. And attendees, you will not be able to unmute yourselves when we get to the public comment period. You will be unmuted by the host if you have signed up to speak. Alex, my script, of course, says now you call the roll, but didn't we just do that? We can dispense with the calling of the roll. So then, all right, so we do have a quorum, correct? Okay.
Yes, ma'am.
All right, so the next item on our agenda is the review of the agenda, and Ms. Jansen, if you could do that please.
Absolutely. Thank you, Madam Chair. So we just finished our introduction and roll call. We will now go over and review the agenda. The next item will be the approval of the minutes from the June 10th meeting, followed by the Commissioner's report with a special presentation from Tim Powell on the Virginia Center for Public Health Informatics, followed by a regulatory action update and then a break. We will be having a lunch presentation from the Chief Deputy at the Department of Housing and Community Development, Pamela Kessner, regarding housing and health initiatives in Virginia. Next slide, please. We will then have our public comment period and then move into regulatory action items. Today we have emergency amendments to the regulations of the patient-level data systems. We also have emergency amendments to the prescription drug price transparency regulations. We will then have another break and then finish up our regulatory items with the proposed amendments to disease reporting and control regulations. We then have a non-regulatory action item for a cremation fee increase request from the Office of the Chief Medical Examiner. Next slide. And then we will have a special presentation on legislative and budget updates from the special session 2 that just wrapped up recently, followed by a legislative update from Mr. Hilbert regarding the development of draft legislative proposals for the 2022 regular General Assembly session. We will then review proposed meeting dates for the 2022 calendar year, followed by any other business, and then adjourn.
All right, thank you very much. The next item on our agenda is the approval of our minutes for June 18th, 2021. Has everyone had an opportunity to review those minutes? All right, then, before there's any discussion, is there a motion to approve?
So moved. Second.
I'm just going to say Jim made the motion and Jim seconded the motion. I know Alex will sort that out. All right, is there any discussion or comment or changes?
This is Patricia. I had sent Alex a small editorial bit of feedback, but nothing significant.
Okay. But no real, okay. All right, then Alex, could you call the roll, please?
Absolutely. Mr. Kreitzer?
Yes.
Thank you. And then, all right, Mr. East is not with us. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. And Ms. Whipple?
Yes.
Thank you. The vote is 14 for the motion, Madam Chair.
All righty, so the minutes are passed 14-0. And it is now time to move on to the Commissioner's report. Dr. Oliver, I was so hoping to see you today, but at least we can see you on screen.
Glad to be here. Can you hear me okay?
You can.
Excellent. Good morning, Madam Chair and members of the board. I really appreciate this opportunity to present to you an update on our response to the COVID-19 pandemic. As you know, our response has been a whole of government response through the Virginia Emergency Support Team. A little while ago, a month or so ago, we converted over to a COVID-19 task force that is primarily consistent of VDH with some support from VDEM. And we continue that interagency support. And I think it's important to realize that we're doing this while also taking on a lot of other responsibilities. This interagency work that we do has been absolutely critical in our efforts to support our federal partners in dealing with the repatriation of American citizens from Afghanistan, which occurred over the last several weeks, as well as all of the Afghani refugees who've come through. At Dulles, we have processed, along with our partners in VDEM and Department of Social Services and federal partners in DOD and Department of State, we've processed some 34,000 plus refugees through Dulles. And I know Bob Moskoff is on the line. Bob, did you want to say anything about that before I get started on the COVID-19 report?
Thank you, Dr. Oliver. I will. As Dr. Oliver said, we have processed over 34,000 plus, and we've tested. Fairfax County Loudoun Health Department, our Medical Reserve Corps, have tested about 1,300. All arrivals have been tested. But in addition to that, we've administered vaccines at the Dulles Expo Center. The feds actually did that. But I want to point out that for the first week plus, it was Fairfax County and Loudoun County and our Medical Reserve Corps that tested every single individual that came through in Dulles. Right now, we have guests, and that's the current term that's being used, Afghan guests at Quantico, Fort Lee, and Fort Pickett. The biggest number of these will be at Pickett. We have about 3,000 right there right now. We have an outfit called International SOS that is providing medical support, as is DOD. They are going through the entire medical processing, as they would if they were just coming into the country, including vaccines. They're being tested every 3 days. We're working with the Hospital Association and the community hospitals around Pickett, because obviously there's going to be a big impact on those hospitals there, but we are working with them on a daily basis to be able to answer any questions anybody might have on that.
Do we have any questions?
Okay.
No questions?
Okay, thank you, Madam Chair. I'm going to
just
keep going now.
Okay. Can I continue, Madam Chair? Before starting in on our COVID-19 response, I wanted to let you know that we have an important update regarding accreditation. We had talked about that previously at a prior board meeting, and we've received our full accreditation status from the Public Health Accreditation Board this past May. This is a really great achievement for our agency. It codifies the fact that we are an agency that's using best practices and is very committed to continuous quality improvement in that work, and that's hardwired into our process. And I believe that will bode well for us going forward, because we intend to work with FAB to ensure that we continue that. Next slide, please.
Norm, can you pause just for a second?
Sure.
Alex, are we trying to work out the sound? Is there anything we could do? Okay. Sorry, Norm.
That's okay. Are you getting that same static with me? So this is the outline for the talk. We can go to the next slide. Quick review of the timeline here. As you all know, we had our first case back in March of 2020, March 7th. Cases rose fairly rapidly. The governor instituted a stay-at-home order on April 1st. Cases continued to rise and got to a little over 1,000 a day back there in May. We began to, over the course of the summer, institute a number of stepwise reductions in the restrictions that had been placed on the Commonwealth. We saw a uptick of cases in the eastern region later in that summer, increased restrictions and enforcement in the eastern region to try to tamp that down, which did manage to have some impact. And then into the fall, we began to see cases rise again, particularly around the November and December holidays, when people were coming together in larger social gatherings. And following those events, we saw a major uptick and surge in COVID-19 cases, which peaked in January of this year, when we were seeing cases upwards of 2,000 a day or higher, actually. I think the largest number of cases that we saw was around 8,000, a little over 8,000 cases in one day in January. Following that, there was a decline in the number of cases. We were quite heartened by that. And we had our nadir in June of this year. The state of emergency lapsed on June 30th. And then during the course of the summer, we saw the rise of the Delta variant here in Virginia, which has had caused a major upsurge in the number of COVID-19 cases. We're now averaging well over 2,500 cases a day. Today, we're going to post another 4,200 cases. And there seems to be, from the modeling that we are looking at, that this will peak end of September, beginning of October, the way that it's going. And as you can see, these cases are more than what we were seeing last year in May and over the summer. We're having cases now that are pretty much like what we were seeing in November of 2020. So this upsurge of COVID-19, like the pandemic throughout its entire course, has had a disproportionate impact on our population in the Commonwealth, with some populations being harder hit than others. And if we go to the next slide, one of the things that we've taken a look at is how COVID-19 has been particularly hard on those people who are living in poverty. This bar graph shows that at a state level, we have 97 cases, this is death rate per 100,000. But for those who are at 40% or more of poverty, that rate is at 181. And you can see as your poverty level decreases in any area of the Commonwealth, the rate of death also decreases. The largest disparity can be seen here between those people found in census tracts who are living, who are in census tracts with the greatest percentage of people living in poverty. And what we've been able to find out there is that those persons are about almost 2.5 times more likely to die of COVID than those with the lowest, who live in the lowest poverty census tracts. Next slide. This slide depicts the rate of vaccination and as a ratio to the vaccination rate among whites, as well as ratios regarding cases, deaths, and hospitalizations. So what you can see here, for example, is that both the case incidence and the deaths among Blacks and Latinos are, in the case of Latinos, almost twice as high as whites, and deaths among Blacks almost twice as high as whites as well. And that shows that disparity, that inequity that we saw with respect to poverty also exists across racial categories. Next slide. There's also a inequity across geographies, with urban areas having a lower age-specific death rate compared to rural areas, as is depicted here in this slide. Next slide. Testing has continued to be done, obviously, to find people who've been infected by COVID-19. As of late May, across the Commonwealth, we were seeing an average of about 32,000 tests. That's both antigen tests and PCR tests being conducted every day. Over this entire pandemic, we've seen increasing percentage of antigen tests, which reflects the increased supply of those tests that we've seen. Testing is extremely important as part of our containment strategy against COVID-19. And one of the really important things that we've launched is a program to do testing in the K through 12 schools. If we go to the next slide. We have a program, VISTA, that we have been funded through CDC to implement here in the Commonwealth. Some 56 school divisions, public school divisions, and 25 private schools have expressed interest in participating in this COVID-19 screening testing program. There's about 1,000 school campuses, some nearly 650,000 students in these jurisdictions, and over 86,000 teachers and staff. Our K-12 testing team has been facilitating one-on-one calls with the interested schools and the local health districts, have been collecting data and information through surveys to confirm commitment to of these populations to test, setting up testing schedules, start dates, and so on, and providing the resources they need to conduct these tests. We are in the process of getting a vendor who will carry out this testing in all of these schools, and we'll be probably signing off on that contract later on this week. Cases that are identified through these screening programs, VDH will help respond to those cases and any outbreaks that occur in schools. And if there are outbreaks, we will, of course, also include outbreak-related testing and the purchase and distribution of home self-test kits to those who are known to have been exposed or have symptoms. Next slide. You will recall us talking a lot last year about our box it in strategy. An important aspect of containing the spread of COVID-19 is that strategy, which we are still trying our best to ensure is implemented across the Commonwealth. The idea, of course, is to identify early people who have COVID-19, isolate them, find out who their contacts are, and quarantine those contacts, and in that way help prevent the spread of COVID-19. Today, we have about 1,100 people who are supporting our case investigations and contact tracing efforts in the local health districts. We had over the course of the summer, as the cases were declining initially, we used that opportunity in the local health districts to promote existing case investigation, contact tracing staff into more advanced roles in our COVID-19 response to focus on setting specific needs and response to other aspects of our COVID-19 response in schools, businesses, and congregate settings. With the rise of the Delta variant of the virus that causes COVID-19, we have ramped up our efforts to recruit and train again a new cohort of case investigators and contact tracers. We're working with the Institute for Public Health Innovation to get their assistance in increasing the numbers of CIs and CTs and training them so that we can keep up with this surge in the virus. There's always been a focus to hire and a concerted effort to hire people in this effort who have language skills so that we could be sure to reach those communities where English is not their first language. And we also have sought to ensure that this workforce is diverse so that it reflects the people that we are reaching out to in our containment efforts. As you can see from this slide, in the course of the pandemic, this expanded staff in VDH has contacted a little more than 75%, or about 466,000 reported COVID-19 cases, and 58% of all COVID-19 cases have actually completed a case interview. Another major initiative in our containment effort is our COVIDwise app, which is an exposure notification app that we launched, and we're the first state to do so. That app has really been amazingly popular across the state. We estimate that 1 in 4 Virginians aged 18 to 65 who own a smartphone have downloaded the COVIDwise app. In addition, there's about another million who have iOS or iPhone users who've downloaded or rather enabled the COVIDwise Express app on their phones, which is something that's packaged as part of the operating systems on the iPhones. This is a powerful tool that really helps with our containment efforts. Next slide. I want to give a shout out to our community mitigation team. They have been outstanding in our efforts to mitigate and help stop the spread of SARS-CoV-2. With their assistance, we were able to put together a public health emergency order for K through 12 public and private schools that mandated the wearing of masks indoors in these schools for all students, faculty, and staff. The reason why this was done with the governor's approval was that we really wanted to ensure that this year our children would be able to have in-person instruction. And in order to have them have that opportunity, we wanted to make sure that their school environment was as safe as possible. We knew that wearing masks would protect those under 12 who were unable to be vaccinated, those over 12 who were still not vaccinated, and of course we would attempt to vaccinate as many of them as possible. And for those who are vaccinated, we knew that and know that breakthrough infections are indeed possible, and we wanted to make sure that everyone was safe from the spread of the virus. Next slide. VDH has adopted the CDC's recommendations for fully vaccinated people. which meant that even for those of us who are fully vaccinated, we should wear a mask in indoor public settings, and communities that are experiencing substantial or high transmission of SARS-CoV-2, which in the Commonwealth of Virginia is every locality. There are scant few counties across the entire United States that have low transmission. The entire United States is red like this. So we continue to promote masking as a very critical prevention strategy, especially right now, as I said, since all of our communities are experiencing high levels of community transmission. Next slide. The best defense against COVID-19 is, of course, vaccination, and we're trying to reach that section of the population that has not yet been vaccinated through a massive communication and educational effort. Our communication campaign thus far has been very successful. As you see here, we've had over 1 billion combined impressions. An impression is, think of it as a viewing of a website or an ad or that sort of thing. 65 million impressions through our satellite media tours, where a person sits and does, in the course of several hours, interviews with 20 or more media outlets, and then it goes on from there, because those different media that were then picked up by others, and that is why it results in such a widespread number of impressions. We have a communications hub, which is used by others to obtain resources and materials that they can use in their local areas for communication, and some nearly 80,000 engagements with that hub have occurred. There have been a couple several town halls that have been conducted that have resulted in 500,000 impressions. And one of the things that have been done by our communications vendors is to establish a program of community ambassadors, people who get on social media and help spread the word about the need to get vaccinated. Next slide. One of the important things we've done in the course of this communications campaign is some research, which helps to benchmark what we're seeing in the way of behavior change, evaluate that public sentiment, and adjust our communication efforts accordingly. We were able to use this research, for example, to really target more our communications to physicians, nurse practitioners, and other licensed independent practitioners, and to really have an impact on incentives for the vaccination campaign. As I said, the communications hub has been used as a resource by our public information officers in order to give them materials that they could use, and our community ambassadors have really been a great aid. Next slide. I should say that this work has been really aided by funding through first the Coronavirus Relief Fund that gave us about $6 million for communications work. We got a grant through the CDC that gave us another $6 million, and the governor's budget to the special session, the last special session of the General Assembly, included $12.5 million for a community communications outreach starting this fall, and we'll be signing. In fact, I think I just signed the contract for that with a vendor that will be starting this work very shortly. This slide just summarizes some of the work that we've done recently. I mentioned the satellite media tours. Both Dr. Avula and myself have done those this summer. Op-eds, radio tours, lots of televised town halls and other things. Next slide. So this data is a little bit old. It's from August 27th. We're doing better than this now. We have some 76% of the adult population 18 or older vaccinated with at least one dose of the vaccine, and over 68%, I think, who are fully vaccinated. This has been quite a big achievement for us. Next slide. We've been able to vaccinate this many people through a number of channels: the hospitals, local health departments, private and other community-based practitioners, as well as pharmacies. As you can see here, the pharmacies are by far the place where the majority of the vaccinations have occurred, and our pharmacy partners have been critical to reaching a wide swath of the population with the vaccines. Vaccine being administered by medical practices and other community partners is a growing channel for us. We have over 2,500 providers who are doing that right now. One of the things we've been able to do is through our state pharmacy here in the health department, is to break up the Pfizer and Moderna pallets that come with 1,100 doses, and break those up so that a provider who wants just even a handful of vials or one vial is able to get that. And that's been an important way in which we've involved them in the vaccination campaign. Next slide. Since I last spoke to the board, I wanted to just give you a little update of what's happened regarding the vaccine management. This quarter, we were able to achieve the goal that was set by the Biden administration to vaccinate 70% of adults getting at least one dose of the vaccine by July 4th. We did that a couple of weeks earlier, but in mid-June. And as I just mentioned, we are around 76% of adults receiving one dose of the vaccine. However, now, reaching those who have yet to be vaccinated is still a major goal of us, for us. This is important for a number of reasons. With the Delta variant and its increased infectivity and transmissibility, getting 75% of the population vaccinated, which was a target of ours that we achieved, is probably not enough. We need to really be shooting for 85 or more % of the population getting vaccinated in order to really get herd immunity. The uptake of the vaccine has varied across age groups. If we go to the next slide. Older populations have been much better about getting out and getting vaccinated than our younger populations. We've as part of our communications campaign recently, we've made a real targeted focus of that communication on those 18 to 30, which is a group that's the least likely to have gotten vaccinated at this point. So our communication efforts are really focused on that, as well as some of our other targeting in the vaccination campaign. We can go to the next slide. We've also really strived to achieve equity in the distribution of the vaccine across racial and ethnic categories. In an earlier slide where we were looking at that rate ratio between these communities and whites, you may recall that we had in the Latinx, Asian American, Native American communities, we were actually vaccinating at a higher rate than we were in the white community, and this is depicted in this slide as well. While we haven't quite achieved parity between the African American and white community, we are approaching it. The ratio is about 0.9. And that's a huge increase from where we started out when it was about 0.3. So we are continuing to target these communities to make sure that the most vulnerable populations are in fact getting vaccinated and protected against COVID-19. Next slide. I wanted to remind you that our strategies around vaccination are pretty much these that are listed here, and we continue to use all of these strategies today and going forward. We've adapted them some to the needs of various communities and the sort of changing landscape of what we face in the vaccination campaign. We transitioned, for example, in this past quarter since the last board meeting to doing a lot more targeted outreach to do the vaccinations, really reaching those communities that either have problems with access to the vaccine or where we know there is some vaccine hesitancy. Next slide. So the key groups that we knew we had to really target were healthcare providers. We wanted to ensure that they had the ability to talk to their patients about getting vaccinated and have vaccine on hand should they be able to convince them to get vaccinated. We knew from all kinds of research that we've been doing with our communications vendors and others that healthcare providers were and are a very trusted messenger, even in communities where vaccine hesitancy is quite high, and being able to have them be able to give vaccinations would be critical to increasing the numbers who got vaccinated. African American community was one that, as you saw, we still had a ways to go to achieve some parity with white community, and we knew that there was some issues around access and some hesitancy that we wanted to overcome. Likewise with rural Virginia, and among law enforcement and public safety officials, we knew that the vaccination uptake was much lower than it was in the general population, and we took on a special effort to reach out to them. I mentioned that our communications efforts around the Gen Z population, 18 to 30, and that campaign is ongoing. We have also been talking to employers throughout the Commonwealth about and encouraging them to take efforts to educate their employees about the importance of getting vaccinated, and many employers are in fact doing just that. Next slide. The adolescent vaccination has increased over the summer in preparation for schools. We have, I believe, I don't have the number right in front of me, but I think somewhere around 54% or so of those 12 to 17 who have gotten at least one dose of the vaccine. So the uptake there has been good and is increasing. You all know that the emergency utilization award was amended by the FDA, and third doses were approved for immunocompromised persons, and we estimate that that's about 3% of the Virginia population, and we've begun that campaign of getting that third dose to those individuals. Immunocompromised persons, we have found, do not mount enough of an antibody response to be protected with just 2 doses, so they need that additional dose to complete their vaccination and become fully vaccinated. There's been much discussion about a booster, which I'll get into in a moment. But in the meantime, I just wanted to mention that, of course, the Pfizer and the Pfizer vaccine got the full licensure towards the end of last month, and that applies to those 16 and over. The EUA still continues for those 12 to 15. Also recently, the governor issued an executive directive, number 18, that state employees will have to get vaccinated against COVID-19, and if they choose not to get vaccinated, then they would have to submit to weekly testing. That executive directive went into effect yesterday, and state agencies are in the process of getting a clear picture of how what the vaccination status is of all their employees, and setting up programs for doing the weekly testing of those who are either not fully vaccinated or who do not wish to get vaccinated for whatever reason. I don't know what's happening at other agencies, but at VDH, we have about, I would say, somewhere approaching now 90% of the employees have recorded their vaccination status, and of those who have recorded their status, 90% are vaccinated and only 10% are unvaccinated. And we're in the process of obtaining a vendor who will then do the testing of those who are not vaccinated on a weekly basis. Next slide. So we set a goal for ourselves of getting 75% of the population vaccinated against COVID-19, and we are approaching that. We have, as I said, 76% that have had at least one dose. We need to overshoot that target in order to ensure that we can really stop the spread of SARS-CoV-2 here in the Commonwealth. Next slide. The situation we're facing this fall is rapidly evolving. As you know, the Biden administration has said that it wants adults, it wants us to do boosters for those who've received the mRNA vaccines. It's unclear at this point whether the FDA or CDC have conducted enough work around this to ascertain whether this is something that really ought to be done. It's our understanding that they will meet on this September 27th, I think was the last date that I saw. And we'll vote on whether or not we will be doing or whether or not they would recommend these boosters. We are planning now at VDH and in our COVID-19 task force to various scenarios around this. We're doing some active planning on that. In fact, we're taking the most conservative approach and planning for what would be the most difficult scenario, and that would be having to do boosters for anyone who's received their second dose of the mRNA vaccine 6 months ago. That would cause a huge surge in demand for boosters in just right away at the end of September, beginning of October. And so we're preparing for that. Next slide. As part of that planning, we're doing that in a number of different ways through our local health districts, central office, and local health districts are obviously collaborating a lot on this. Here at the central office, we've really focused a lot on looking at these different channels, doing modeling on how much additional demand these channels can handle. That modeling indicates to us that the pharmacies, providers, local health districts, and others will not be able to meet this surge in demand. And for that reason, we're in the process of putting into place, getting the funding for and getting vendors to establish community vaccination centers, as we had done earlier in the vaccination campaign. The plans are to do this in some major population areas in Fairfax, Loudoun, Prince William County, the Richmond area, out in the Tidewater region, and in that way augment those other channels so that we can deal with the surge. Next slide. So as I said, we're going to reestablish those community vaccination centers. With the increased surge, we probably will need to reestablish appointment-based vaccinations and not just walk-in clinics, which would, in order to really ensure the efficiency and smooth operations of these CVCs. The hospitals and healthcare systems will focus on their staff and their patients. I mentioned that we've onboarded a little more than 2,500 community-based providers, and we want to ensure that they'll be able to do as much vaccination as possible. We will continue to work with our pharmacies. The federal program that existed that allowed the pharmacies to really focus on the long-term care facilities is not going to be set up again, but we hope that our local health departments can partner with pharmacies in their districts to assist them in taking care of those long-term care facilities. We will maintain our mobile clinics and targeted clinics in the course of dealing with the increased demand for boosters. We want to make sure that we continue to do the vaccination effort in an equitable fashion, and these mobile clinics and targeted clinics will help us to do that. That small shipment redistribution program is what I refer to that our state pharmacy is doing to break up the Pfizer pallets so that our providers have smaller amounts to deal with. And our communication efforts, of course, will continue. I'm going to stop here for questions. I should say that one of the things that we've been doing over the last couple of months is, as an agency, we've taken note of a number of the challenges that have been presented to us as a public health agency throughout this pandemic, and wanted to really look at our agency and look at public health in general with a new eye. See what those challenges were and figure out how to address them. Things around our data handling, data analysis, and so on. And really take this opportunity to begin the process of building ourselves back better. One of the upsides, if there are any, to this pandemic is that public health has received a big influx of funding through our federal partners, increased grant funding, increased funding through the American Rescue Plan Act, ARPA. And we wanted to use these funds to not just plug them into the usual spots for short-term sort of gain, but as capital to really help us transform public health. And we're going to have our partners from Deloitte who've been helping us in this process talk about that after we take some questions from my presentation. So with that, I think we can, Madam Chair, we can open it up for questions.
We're going to start with Ms. Hines, and then I hope Alex can help me see who online has questions, because I think maybe between the two of us we can get it. Linda?
Thank you, Commissioner Oliver, for that very comprehensive report. I did have a question. Given the rise in COVID cases, the positivity rate, and deaths, are there any plans to reinstitute the state of emergency?
No, there are no plans at this point to reinstitute the state of emergency. The only thing that has been done is my continuing the public health emergency, but that is not as comprehensive as the governor's declaration.
Jim Edmondson is next.
I have
Waiting to be called on, or can we ask a question?
Catherine, if you
Dr.
could
Oliver?
if you could signal on the screen, you will go after Jim Edmondson.
Okay, I can barely hear you.
Okay.
Thanks, Dr. Oliver. Just an amazing effort to keep on top of all these things. I'm particularly concerned about vaccinations and protection in the school systems. I hadn't known about the VISTA program. You have a chart about that. The good news is that there are a whole bunch of counties in the Southwest that seem to be pursuing it. Terrific. In my part of the state, in Northern Virginia, there are fewer than I would have thought. What do you suppose the reason is for relatively limited participation in this program?
Thank you for that question, Jim. I don't know if Dr. Filano is on the line. She is head of operations for our COVID-19 task force.
Hi, Dr. Oliver. Can you hear me all right?
Yes, we can.
Great. Thanks for the question. I'd say the themes in general are mostly just concerns about capacity and overwhelm. I think there's a lot on these schools' plates right now. I'm actually pretty pleased at the interest we've gotten. In the beginning, we set a pretty low bar. We didn't think we'd get even 3 schools. But so the fact that we have a few dozen interested, and we're very close to launching our first school. But I do think part of it is workforce and just being concerned as to whether they can handle it. Other themes are they're just not interested. But most of the feedback we've heard is a concern about just being able to manage it. But we're trying to mitigate that through grant funding, helping them hire staff, et cetera.
May I ask one more, and then I'll let other people before I keep going. Another one of the statistics that surprised me is the percentage of different populations, mainly racial and ethnic populations, that have been vaccinated, and the white percentage is almost as low as the black percentage. The last thing in the world I would have expected. Why? Is it politics?
So that's the percentage. So, yeah, the percentage of the population that's been vaccinated fully is across the state is around, 55. No, what am I talking about? I think it's around 60-something%, right, Lori?
Right.
Like 68. And so in some populations, yes, in Appalachia, for example, rural Virginia, a predominantly white population, the percentage is much lower than it is in the rest of the state, and that pulls down the numbers for the white population. If I had to take a stab at an answer, that would be it.
Okay. Discouraging.
It's discouraging. It's a real challenge, and we need to do everything we can to convince folks that they need to get vaccinated. That the way to stop this virus is to put a shot in their arm. We're getting, we're not getting massive numbers, but we're getting some people every day. I mean, if you look at the number of vaccines that are happening every day, it's still, 12, 13,000. So we're chipping away at it, and we'll keep chipping away at it and keep trying to get trusted messengers in those communities to become ambassadors for the campaign, for the vaccination. Hopefully the full licensure of Pfizer and probably the full licensure of Moderna coming up soon will help chip away at that some more. So we're looking forward to that. In addition to the boosters, we also expect that sometime late fall, we'll also see at least the EUA for vaccinating children 5 to 11 years old. So additional people to add to protection for against SARS-CoV-2.
Catherine's going to be next, and then after that will be Wendy. I'm sorry.
Okay.
After that will be Holly.
I had this question about the white population, only 56%. And I noticed that primary care physicians were not included, that I didn't see that were included in booster vaccinations. I'm wondering, I know many of these people might be anti-vaxxers that are not getting vaccinated in the white population, but they're all also, I mean, we know people in our area that have not been vaccinated. And my hope is that if they can go to their primary care physician, they will work with them to convince them this is the right thing to do for everybody. So I wondered, are primary care physicians on that list for boosters and for vaccinations?
Yes, they are. So they, we started a program a couple months ago where our state pharmacy here at VDH is taking the large pallets of Pfizer and breaking them down so that primary care providers, other providers can get smaller quantities of the vaccine. That was a major impediment to their being able to provide those vaccines. We have a little more than 2,500 providers who are currently signed up and prepared to do vaccination, and that will be a major channel for giving vaccinations, including the boosters.
Thank you.
Holly is next.
So I just wanted to comment on Jim's comment and give you some at least anecdotal or man on the street perspective. I see 30 to 35 women every day in the office, and I can guarantee that in my 18 to 35-year-olds, half of them are not vaccinated. And the overriding answer is this unfounded concern about infertility. And I think that is contributing in a huge way. I speak till I'm blue in the face, but perhaps some statewide campaign regarding that, because that is number one what I hear from moms and from the college-age students, that I'm all for a vaccine, but I want to have children. Obviously, it's completely incorrect information. We have been answering that on a one-to-one basis, but perhaps some statewide messaging because it comes up so often. So I think that's part of that 50%, Jim. The other thing is it is very difficult, but we're getting better to convince our pregnant patients to get vaccinated. Many of them are not anti-vax. They all want to wait till after they deliver. We're using very strong messaging. We've had a patient just recently in our practice who passed away a week after her daughter was born, 23, from COVID with no risk factors. So I tell that story every day, and it seems to make an impression. But I'm not at all surprised compared to Jim that 50% number, because that was reflected in my practice every single day. I am not arguing because that's not helpful, but I am teaching, and I have small successes that are very gratifying, but those are the two issues: that I'm not going to do something when I'm pregnant that you can't promise me it won't hurt the baby, and the infertility is remarkably robust, even though it's unfounded. Patricia's next.
I just want to say one thing there, Dr. Puritz. I thank you for those comments. That age group is our biggest challenge right now, we think, and we do have a major communications campaign afoot that's directed to them, and it's been getting a lot of impressions, a lot of hits on. We're going out through social media, Twitter, Snapchat, TikTok, all kinds of different ways to try to reach them. And one of those, and we're taking up a number of those myths, including that one around the fact, the myth that the vaccine will somehow affect their fertility.
Well, perhaps some sort of even a simple poster or something that we could put in OBGYN offices would also be very helpful, although I must say I'm not on TikTok, Twitter, and all of those other things, so I'm not seeing those. But you're not trying to get to my age group. But perhaps something like that we could have in our offices would also just be really helpful, because
yesterday in our office, we had 250 patients walk through our doors. It's a very easy way to get that message out if it's sitting on a bathroom door, literally, where everyone has to pass through. So that may be something else that's helpful.
Okay. Dr. Avula dropped into the chat a link to the work that's being done around our Gen Z efforts.
Yeah, I see it now in the chat. Thank you.
So take a look at that. And Tammy Smith had also earlier dropped in a thing about the communications hub that I told you about. That communications hub has resources, and I'm pretty sure that if you were to go there, you would find there's a thing called the Vaccination Mythbusters Toolkit, and it has posters, stickers, and those sorts of things that you could use. And you could just download that and use that in your office.
Perfect, thank you. And I'll pass that along to the OBGYNs in the community.
Thank you.
Patricia is next, but I just want to dovetail on what Holly's just been talking about, that I wonder if part of the communication is not reaching out sometimes with physical materials. I've been listening to a lot of school boards in the last month, and one of the things I'm keenly aware of is that our school board members often have no idea. I've heard school board members purporting ridiculous myths about what masks will do to children. I am repeatedly hit, well, if you can smell through it, you can't, it doesn't stop germs. And I'm having one-on-one science lessons about the size of molecules on the regular. And I'm wondering if we couldn't send out an FAQ for school boards. I mean, I know that we don't have unlimited resources, but to target physical things at people who are not going to go online, I think sometimes is really important.
I agree.
Well, thank you for that. We have a number of people from our communications office who are on the line here for the board meeting, and I'm sure they're taking note of these suggestions.
Patricia is next.
Sure. So I have an unrelated question, but first, I actually want to tag team on that conversation for the communications folks. I wonder if they could request that the Board of Medicine and Board of Nursing push out those materials to the clinicians who are, have board certification in the state, so that we could, because we get these emails all the time, and that way we could have it at our fingertips to print out in our practices. And then, so my unrelated question, but related to this overall topic, is that those of us in the clinical world are very concerned about the extensive fatigue and burnout being experienced by healthcare workers. And Dr. Avila and I spoke about this just recently. We're hearing about rates of nursing turnover above 75%, even in community-based settings. I speak with nurse managers all the time in ICUs who once again have large percentages of their staff out of work due to infections despite being vaccinated. And these facts, compounded with decreasing availability of volunteer medical reserve corps workers, it all makes me very worried. And I wonder not only what thoughts you might have on this, but also what specifically as a board we can do to support workforce issues, because this has ultimately significant public health impact.
Thank you for that, Dr. Kinzik. Yeah, it's a huge problem, and it's a problem for both clinical medicine, clinical nursing, and so on, as well as public health. The public health workforce has been severely impacted by this as well. And, Dr. Avula and others could speak to this more eloquently than I, but, in some of our health districts, we've lost half our nursing staff. Increased retirement, just burnout, all the things that you know about from being on the front lines clinically. It's a huge problem, and quite often the answer is, people give you are things related to improving individual resilience, which is, you know, that's fine. I'm all for meditation. I do it myself. Mindfulness, I'm a great fan of practicing that. And we all know that it would be helpful if we had more time off, took more frequent vacations, and other things for our well-being. The problem is that the workforce was we were understaffed and under-resourced going into the pandemic. You know, I spent 21 years in a major healthcare system and in primary care, and primary care was under-resourced and understaffed, the entire time. And then you get hit with a pandemic, and we are all very dedicated people who are going to do everything we can to battle this thing. But being under-resourced and understaffed means that it takes a toll. The long-term solution to this is to fix that underlying problem. What we need to do is build up the workforce in primary care and public health. And I think one of the most important things that the board can do as individuals, and we've had some discussion about how you might do that as a board, is to advocate for that, that we need more resources, and the resources need to be sustainable. It's great to get ARPA funds that last for 3 years, but we got to go beyond that. Whatever we build up with that has to be sustained for the future. So an important aspect of that is increasing the workforce in primary care and public health, providing more education and development for those of us who are in those fields, if we do those two things, then I think it will have the wherewithal to then, take that break when we need the break, because we got a deep enough bench that someone else can step into the breach and help out.
Thank you.
I don't know if anyone else wants to speak to that. I can't see everyone who's on, but I know Dr. Avula, Dr. Folano.
I can take a stab, Commissioner Oliver. Good to see everybody this morning. I certainly at the local health district level, this has just been an extraordinarily challenging year and a half, but it extends beyond, public health, right? As I talk to all of my clinician colleagues, they're experiencing the same thing: burnout, turnover, can't fill positions quickly enough. I think as it relates to VDH and the local health district infrastructure, Norm nailed it. Like, we really do need expand the breadth of positions committed, but also the competitiveness of those from a salary standpoint. There's a lot of work happening right now that Commissioner Oliver and Secretary Carey are leading to think about what are the next couple of years of the public health challenge look like, and how do we respond to that. One of those clear cores is the public health workforce. And while I think there are great examples around the state of where health departments have really integrated well with academic institutions, created workforce pipelines, at the end of the day, if for example, the VCU School of Nursing, their nurses come and rotate at the city health department every semester. And that has piqued a lot of interest in this field. But if the positions ultimately can't compete with salaries in the hospital sector, it really narrows the funnel on who would be willing to come into this. And when we only have, X number of jobs per district, so I think Norm's point of advocating, really rethinking what the need is for nurses, for community health workers, for data scientists, and expanding the resource pool to ensure that our public health front lines have what they need.
Thank you for that.
Okay, I think Jim Edmondson has another question. And sorry.
Yes, this, Jen, I have a question. I couldn't find a way to raise my hand.
Go ahead, Anna.
Okay, so I'm up to ask a question. Okay, so I do know the pharmacy now is giving out the booster shots, and I got a couple of calls and from friends and people in the community ask about the guidelines of a booster shot. And so particularly older people tend to, consider to get them booster shots because they get the vaccine probably in February or March. And so I was wondering that BDH has released guidelines on receiving the booster shot.
Okay. So Dr. Chang, currently there's only third doses being given to immunocompromised persons. So there's been some confusion in the terminology there with people thinking of those third doses as booster shots. For people who have compromised immune systems, getting 2 doses of the mRNA vaccine was not enough for them to mount a sufficient antibody response to make them immune to the SARS-CoV-2 virus. So they need the 3rd shot in order to be fully vaccinated. And those are the only individuals right now to whom we're giving a 3rd dose of the mRNA vaccines. There's been a lot of discussion at the across the country about booster shots. The booster shots are for those of us who do not have compromised immune systems. The idea behind that is that there's been some indication that after 6 to 8 months or so, the efficacy of the mRNA vaccines declines slightly. And with the booster, it is ramped back up. And particularly for some more vulnerable populations, the elderly, folks in nursing homes, people with chronic medical conditions, perhaps, getting that booster could be really important. The CDC and FDA are going to take a look at this. They're looking at it now. They have a meeting scheduled, I believe, for September 27th, where they'll make a decision about the science behind this. So I expect that by the end of this month, we will find ourselves providing those boosters. And the question will be whether we will tell people that they need the booster 6 months after their last dose, or 8 months after their last dose, or between 6 and 8 months. We don't know what's going to be said. VDH is planning for 6 months. And the reason why we're doing that is that would be the most challenging for us to tackle. And so we want to be ready for the most challenging scenario.
Yeah, that was what I know, but some pharmacy like Rite Aid and CVS also already give out the booster shot, and that was the confusions, to people. So, and I know we are in the process and trying to get more people get the 2nd doses. And then we talk about, the 3rd shot and the booster shots and coming next couple months. So, and I was wondering if BTH has, a campaign that send out a clear message that reduce the confusion.
We're doing our best, Dr. Zhang, and I would hope that the pharmacies are not giving boosters now and focus on immunocompromised. Dr. Swartz might want to speak to that. I think that they're pretty clear about it. Pharmacies that I've talked to, they're very clear on this. Danny?
One of the dynamics that we're seeing, because the CDC, with that 3rd dose recommendation for the immunosuppressed, the CDC was very clear that we are not to require any kind of proof of condition. You don't have to bring your medical records. You don't have to bring a doctor's note. And so the process really just allows for what's called self-attestation. where the person basically says, hey, I'm immunosuppressed, I'd like my third dose. And so what's been happening, we've had about 31,000 Virginians who have received a third dose at this point. Now, the bulk of those are legitimately people who are immunosuppressed. Our 3% estimate of adults in Virginia was about 120,000 people who would qualify for that third dose. But what is happening, the stories that we're hearing are that people will talk to their doctor is doing the right thing and saying, we don't have an FDA approval for boosters yet, you're going to have to wait until that comes out. They then go to a pharmacy where they self-attest and they say, hey, I'm immunosuppressed, or hey, I'm here, and they get their shot. And that's putting providers in a tough spot. And so we have just continued to reiterate the guidelines to our pharmacy partners. Stephanie Will and Alexis Page have done a great job of gathering them weekly and reiterating that. But it is this, that we're in a tough spot probably for the next 3 weeks or so until we get more formal booster recommendations, because people are finding loopholes to do this, and that bears down on providers who are trying to do the right thing.
Yeah, thank you for your answer. Yeah, that's what's exactly what I see now on the ground. Yeah, and
just to add to that from a pharmacy perspective, I same thing as Dr. Vola said. I make people self-attest that they have these conditions. I tell them I'm not the police. It's not my job to tell them whether or not they have it or not. I tend to, just say what Dr. Oliver said, that there's evidence only in this patient population. There's no real reason that you have to get it now as opposed to two months from now. But yeah, I'm with you, Dr. Jang. I think there is some confusion from the confusion, but we probably have only done a handful of booster shots, to be real honest with you.
Right, I believe the order I have now is that Jim Edmondson has the next question and Holly has another one after that. If anyone else has questions, please put it in the chat, maybe that you want to be next. I'm trying to juggle, and I might not be as good at this as I should be.
I have an anecdotal observation, just confirming what Anna and Dr. Avila have observed. Pharmacies in our area are giving shots without respect to limiting them to immunocompromised people. That's just the way it is. My sense is that there's an economic incentive to do it, and it leads to a question probably for Dr. Avula. One of the reasons there's an economic incentive for pharmacies is that they've got vials that are going to go unused and would otherwise expire. What's your sense of around the state of the loss of the use of or utility of vaccines because they're just expiring?
Certainly something that has been happening, Dr. Edmondson. I mean, when we really saw the drop off in demand, the federal guidance was, hey, we expect there to be a certain degree of waste, and we don't want that to be a barrier to getting anybody vaccinated. And so for that provider who sees a patient come in at 4:30, they finally are ready to get vaccinated, don't let opening a 10-dose vial be the reason that person doesn't get vaccinated there and now. So, I think we were really good at managing waste while we had really high demand. When we got into June and that demand really dropped off, we changed our messaging to providers and said, hey, it's more important right now that we get each individual vaccinated than it is to worry about wastage. And so we have seen wastage increase over the last couple of months in a calculated way, right? We weren't being willy-nilly. The guidance we gave to providers was that your wastage should never really be more than one vial if you're managing your inventory through the day. I think that is now creating this scenario where people are maybe opening a vial to vaccinate, and instead of discarding the rest of that, they're saying, okay, we anticipate boosters are going to come down the road maybe in 3 or 4 weeks. We might as well start this now. So, that's not going to be the party line, right? Where the guidelines are what they are. There's no formal recommendation for boosters yet, but clearly this is happening. And I don't have a sense of the degree to which it's happening, nor do I think that, spending a lot of time figuring out how to police that is going to be very fruitful right now. The way that we would potentially enforce that is that the CDC has basically said, let's say for Pfizer, Pfizer has been fully approved now. Typically, a full licensure of a vaccine means that providers have the ability to pursue off-label usage. What is different in this scenario is that all of the COVID vaccine is still coming through the federal government to the state governments, and there's a CDC approval provider agreement that everybody's got to sign. And so the CDC is saying, providers, if you want to keep your agreement current, you've got to use this according to the guidelines. And if you don't, you risk having your CDC provider agreement pulled. So that's a step that potentially we could take, right? If we hear that this is a huge problem and people are out there using things off-label, we could rescind their provider agreement. I just don't have a sense of how much it's happening and whether we need to take those steps, and would that be counterproductive in 3 weeks when we actually need those providers to be vaccinated? It's a tough spot.
One more. Another observation with a question attached to it. The Washington area metro system has decided that they're mandating their staff, particularly those with public contact, to get vaccinated and to wear masks. And they have provided an incentive for the staff to get vaccinated by requiring that they get tested weekly, and guess who has to pay for the tests? The unvaccinated employee. Is that happening anywhere in Virginia?
Danny, you want to deal with that one too? I mean, it's happening in a number of different employment settings, is the short answer, but Danny may know more.
Yeah, sure. So there are lots of employer requirements, some that started prior to the FDA licensure, and then we've seen a whole slew of employers start to require it since the FDA licensure, full licensure of Pfizer. Now, the nuance that you're talking about is like the disincentive for those who don't get vaccinated. And we've seen a range. I mean, some employers are not even giving the testing out, right? They're just saying you've got to get vaccinated, or there are going to be disciplinary consequences. Some employers have done more creative things. Delta had a big announcement 2 weeks ago where they said, if you are unvaccinated, you have to pay $200 more per month towards your health insurance premium, because that's what it's going to cost us to manage the risk of you getting hospitalized. And then different institutions have handled the vaccinate or test differently. Right now, by and large, testing, if you're insured, is still available and covered by insurance. And so, every employer is just kind of handling it differently. Some are saying, hey, you've got to figure out how to go get tested. Some are setting up or contracting in-house testing to do it. I do think the concept that you're raising, which is how do we, not only for safety of the workplace, but also, to make the negative incentives to not get vaccinated strong enough that people just say, okay, let's get vaccinated. It's going to be better this way. I see more of that happening.
Economic incentives work.
Yeah,
I guess
absolutely.
that's my message, and I hope that more major employers will take that step.
Okay, so Holly is next, and then Benita is after Holly. Again, if you want to go after that, please put yourself in the chat.
So as we've been sitting here, I went on the Virginia Department of Health website to find this Mythbuster toolkit, and I am unable to locate it by using search phrases, by using Gen X, by trying to use the link that was up there. I might have typed that part wrong, but my point is I'm interested, I'm here, and I want to find something, and going on Virginia Department of Health, I cannot locate it. So if it's that difficult, and maybe it's my phone, this is, I think, the phase point. I have a vested interest. I sit on the Board of Health. Your average person or someone in office, it's got to be easier to find this information. And I think sometimes we have a false sense of how well we're communicating when we have everything online and by a link. Because I can't. Mythbusters, Gen X, Information for Health Professionals, COVID-19. These were the code words, search words I put into the site on my phone. So I just bring that up as a lesson. And sometimes we think we're communicating, but perhaps it's not really working as well as we would like. And sending out sometimes old-fashioned, something in paper really can work, or making it significantly easier to access on your website. So I see this, but this is too difficult. I mean, if I'm thinking I want COVID information, now it says it's an internal site for staff and partners. I don't even know what that means. And this is too hard. It's simply not, that's not a usable way to get information out to the people who are really on the front lines, spending every day pleading with patients to get vaccinated. It can't be on an internal site. Why are we hiding it there?
I agree.
Somebody want to respond to that?
Thank you. I will work with,
you want to speak to that at all?
No, I was just going to say, I'm going to work with Maria Repis and the communications team. I don't understand, when we say partners, I don't understand why we wouldn't have the OBGYNs as partners. So we'll figure out the way to work this. We'll fix it.
But I also do think that, again, if I'm a patient and I say get trusted information, I can go on Facebook and find 18 sites in 4 minutes that tell me I'm going to be infertile. I shouldn't be able to go to my Department of Health website and work this hard to get active. This is why we're losing the battle. No 20-year-old is going to work this hard. This is not a good way to communicate. And I think we're missing the boat if we think that that we're doing our job to communicate effectively. We're not communicating effectively, in my opinion.
I think having communication is not the same thing as disseminating communication to the right parties, and I agree, it's hard. Benita's next, and Joe's on that.
Well, yeah. Hold on. Is it possible for this information to be like a Mythbusters toolkit to be right front and center on the website so that practitioners and the public can access that information? Because I agree with Holly.
Yeah, we could certainly look into that. The link that was dropped into the chat for both the Gen Z efforts and the communications hub, I don't know if that's an internal site.
Do you mind if I weigh in, Dr. Oliver?
Please do.
I'll explain it. So we have 2 hubs. One is the internal one, the communications one. One is public facing, and that is the ambassador hub for community engagement and our volunteers. The communications hub that everyone is referring to was developed by our vendor, and the driving reason they wanted to make it internal is because the information changes rapidly, and we do change it in as fast as we can. My concern is that we do give it out to reporters. If reporters get a hold of it, I'm very concerned that this now turns into the information is constantly changing. You know, VDH is making all these changes. We wanted to keep it internal so that, as I said, partner organizations that we work with, this was also primarily a resource for the local health districts to use so that they could print up information as they needed it. We definitely wanted to keep it internal for the rapidly changing information reason, and also because we wanted to be able to be aware of who was using our information and how. Now, we can always revisit this discussion. We are doing a brief change in vendors right now. VDH will eventually take over this communications hub, the link that Dr. Avula dropped in the chat. My vision for it was to make it a permanent resource for local health districts if this time ever comes, in the non-COVID-19 times. It was something I wanted to keep around permanently. I hope that clears up. I'm not saying no, we could make some of this information public facing, but we would also have to assign staff to make sure that if there are any changes, any CDC or ACIP guidance, we have to change that information immediately. It is a huge task. I hope that clears up some confusion.
So it clears it up. I understand your hesitancy, but this is my point. We're sitting at a meeting and we're discussing how to communicate, and we're getting a false sense that we're doing a good job. I'm sorry to say. If an OBGYN or a patient can't go to the Virginia Department of Health website, and get some information that is so useful, that's a problem. We're patting ourselves on the back about communication that I don't think is really useful. Data for data's sake, or handouts that are on some site that's internal, it's not useful to say to me, oh, you can print them off. There's not bandwidth in anyone's day to work this hard to find your good information. So I really think you have to rethink, when there's so much misinformation out there, what is the best use for us to be able to communicate clearly and be seen as that trusted messenger. That's my point. I understand all the ins and outs, but I don't feel we're doing our job and we're serving the people correctly in the way it's currently being handled.
I think it's absolutely the truth that we need to improve our communications. That's one of the things that has bubbled up as a major need, and as we transform ourselves for the future, and is a major need now. There's different aspects to this, however, that I think we really need to keep in mind. Our communications have, while there's plenty of room for improvement, the numbers and the metrics that I gave you in my presentation are in fact true. We have had millions and millions, in fact, over 1 billion impressions on that social media stuff. And you know, if I wanted to call my daughter right now, if I called her on the phone, she would not answer. If I text her, I will get an answer. That generation is very geared into that, and we've targeted them, and we've been getting lots of impressions from it. So we believe that our communications campaign is effective in reaching out to that population. That being said, I totally support what you are saying, in that we need to provide providers like yourself with materials that they can use to educate their patients. Like you said, you got 200 to 300 people coming through your doors every day who, if there was a poster or a handout, a little, refrigerator magnet, whatever, with good information on it, it would be really helpful. And we need to think about those channels as well. So I agree with you on that. And I also think that our website could stand a bunch of improvement, and we need to invest in that. This gets back to the workforce issue. So Maria, who's our communications director, sort of alluded to it, right? She said, yeah, we could put this on the public-facing part of our website, but this information changes sometimes daily. And so who maintains that? And well, that speaks to the fact that we're under-resourced and understaffed, right? So that maintaining a website becomes a roadblock to our doing the right thing, right? The right thing is get this out on a public facing page, maintain it so that it's accurate every single day. No matter when you click on it, it's accurate. And having the staff and the data scientists and the web page managers and whatever, having the people there to be able to do that work. So we have to work on that as well.
And if Dr. I just want to briefly add to that, just two things really, really quick. We are aware that the website is a bit of a challenge. Deloitte is doing some work with Joe Hilbert and myself on this very matter. I've gone through a number of websites. They've interviewed individuals to take a look at our website and seen the challenges with it. We are considering a website redesign. I just had a meeting about that earlier this week. And the second thing I want to announce is that just on Monday, we have a brand new vendor working with VDH, a communications PR vendor for the next 12 months that is sufficiently funded to answer a lot of these questions. And I do want to speak to the bit of the fatigue that we've kind of had on the comm staff. Again, we were working hard, particularly with Dr. Zavula and Oliver on these issues. And so we're really looking forward to this new vendor who won this award just several days ago with some fresh ideas and kind of a fresh perspective on things. And the concerns that you've brought up are in their scope of work, and anything additional I can also bring to them. For those who are wondering who it is, it's the Rheingold PR firm up in Northern Virginia. So, and they are going to handle about 3 campaigns between now and the end of the year. It's the 5 and up vaccine, holiday mitigation and messaging, and the 3rd dose / booster shot campaigns. So you're going to be seeing an influx of communications efforts. So if you do have concerns, please email me directly. We can certainly incorporate them into this new vendor's scope of work.
So just before I let Benita follow up, what I'm going to suggest is that everyone who has concerns send them to Maria as she asks. But just a reminder that the Board of Health is made up the way that it is because we all represent different constituencies, which means we're going to see things on the ground. We're not, as all of you know, this is not monolithic. And what I would suggest, Maria, is when we do have new vendors, that perhaps they can reach out to some of the board members so that the constituencies that we represent, we can at least talk about the communication concerns within those constituencies, and that we then in turn relay those on so that the communication becomes a little more, I guess, a little less siloed, a little bit more from our particular concerns. So if everybody would go ahead and send your concerns on to Maria, copy me, would you, so I just have a sense of it. And yes?
Yeah, I would appreciate that. And since the vendor just started and they're on for 12 months, and we can discuss having a separate meeting to go over these, and they can give you an overview of what's currently in their contract for their scope of work and what they have planned in the future. And we can discuss that. Absolutely.
Thank you. Okay, Benita, you are next. And then Anna has another question. I think that's all the hands I have at this point.
So thank you. I know that it is a work in progress, and keeping up with communications is extremely difficult. And I do have a 23-year-old daughter who almost never goes on Facebook, but a lot of folks her age listen to podcasts, so I know that could be a possibility. And then she will go on a website like the Department of Health, and I do see where you have a great COVID hub, and maybe include some of those Mythbusters in that hub might be good. So my question though, oh shucks, hold on. When you were talking about the ratio to rate for white population, that slide, I guess what hit me was the Latinx community, which actually has a better vaccination rate than the white population, but has the highest hospitalization rate and case and death rates, which are comparable to the Black population. I just wondered if you had some thoughts and concerns regarding that group.
The inequities that we see in the case incidents and death rates in Black and Latinx communities, I think is related to a couple of things. One is that these communities, people from these communities make up a large proportion of those working in so-called essential industries. So if you look at a construction site, you go to grocery store, you ride a bus, you're going to see primarily Black and brown people who are doing those jobs. Those are jobs where they worked and continue to work through the pandemic and public-facing occupations, and it puts them at higher risk. Another thing that contributes to it is these populations are also populations that have decreased access to healthcare, and either through lack of insurance or for other reasons, and that impacts their health status as well. And there's an overarching problem, which is the one of systemic and structural racism. And it's the reason why, we even had a legislation in the GA labeling racism as a public health crisis. How that factors in here is that systemic and structural racism is the underlying problem that leads to inequities in health status to begin with. So these populations, if you were to look at the stats on diabetes or stroke, certain cancers, hypertension, any number of illnesses, you'll find that they are much higher in these populations than they are in the white population. And we know that people who get COVID who have chronic illnesses are at higher risk for serious disease, hospitalization, and death from COVID-19. So all of those factors, I think, lead to the inequities that we see in the case incidents and in the seriousness of the illness in those populations.
All right. Did I miss anybody? Are there other questions?
I think Anna said she had another
Anna,
one.
okay.
Yes. Dr. Oliver, and at our last meetings, you did, mention that the state received large funds from the coronavirus relief funds. You did even ask, required the board to give a recommendation how to use those funds effectively. So the essential goal for using that fund is to transfer the VDH. So we just my question is that whether that VDH already made a recommendation to the governors, and what is the status of it, and what are the priorities that the VDH utilize the fund to invest to help to build a capacity. Even at this meeting, we already identified the several areas of challenges and the shortcomings. All are required resource to do so. Thank you. Mm-hmm.
Well, thank you, Dr. Zhang. Your check is in the mail for that wonderful segue into our presentation from our Deloitte colleagues who we've brought on board to help us with that transformation project. So, Madam Chair, if there's no other questions, perhaps we could go to that.
Okay.
So we are going to take a brief, about 10-minute break right now. We're scheduled for one at any rate, and we need to get some things up on the screen for Deloitte. I actually do have one question, but I will hold mine until we get back from the break.
Okay.
And just prior to Deloitte, because it may be an ask and answered kind of thing.
Okay.
All right. So we're going to take about a 10 to 15-minute break. Do as you will. let's, 11:15, let's do it.
Nobody outside of this, it's just us. Of course. So no one online is, yeah, like when that's all of us on status, it doesn't.
Yeah. I have the sense that they could hear even when we could not. Yeah. So, yeah.
Absolutely, we'll do that. We're going to come back now, and I'll let you go first. I'm going to ask my question, and then we'll move on. All right, folks, we are back. I'm going to ask Mr. Hilpert to talk about this communication issue. If it's all right with everybody, I will ask my question for Norm, and then we will move on to our next presentation.
Yes, Madam Chair, just wanted to follow up on the discussion we had about the Virginia, the VDH Communications Hub. I had a follow-up discussion with Maria Reppis during the break, and we are going to open up that hub, make that hub accessible to a wide range, to all of the provider organizations that I know of, so including Virginia chapter of ACOG, MSD, the family practitioners, the pediatricians, the pharmacists, the nurses, the dentists, and so we're going to do that. So that all that information on the Comms Hub you will now be able to get. So that should happen ASAP. Certainly.
All right, Norm, I have a question for you. Going back to the mandate for K-12 public and private, one of the things I have unfortunately seen over the course of the last couple of weeks in response to that mandate is some folks who I think are about to get a huge surprise who've decided, well, daggone it, they're just going to start their own schools. I've seen a number of homeschool co-ops where students will be in a building. And so I think what I want to better understand is, in terms of the VDH rules, what constitutes a school? If I just decide I'm going to do a homeschool co-op, but I've got all the students in a building together, am I at school? I know that I put you on the spot.
Yeah, that's a tough question. I believe when talking about schools, we were talking clearly about the public schools, and in terms of private schools, I don't even know what the actual accreditation body is for them. So a non-accredited makeshift thing, I don't think we would. The order doesn't have any jurisdiction over them, I don't think, but I'm not a lawyer. Perhaps you could refer that question to our counsel.
I think I will ask that question to our counsel. And unfortunately, your counsel is not going to have an answer to it off the top of my head. Okay. We'd have to do research on that. My gut is a homeschool co-op is not going to be considered a school, but we'd have to do research on that and consult our education attorney. And I'll talk more to you after about what my concerns are. Dr. Schuler.
Not to belabor the point, but for what Holly addressed and what Joe's addressed right now, in the real world, all of us are busy. We get up every morning. We're off to work, doing something, getting kids into a class, whatever. We take snippets from social media, cable news, some newspapers, etc., to get our information. So the answer lies into, if I end up at my doctor's office today, or at my dentist's office today, or at my vet office today, there should be clear posters and assistance for me to see while I'm sitting there on what's going on and what's factual. Otherwise, I'm not going to get it, because I don't get up every morning and go to the VDH website for my news for the day. I'm just trying to explain what it's like in the real world where we're living our lives each day and where we're going to end up, being at the doctor, at the grocery store, or wherever we're going. That is where the information needs to be posted, and clearly posted, to remind me that I need to do A, B, C, get vaccine, whatever. So I applaud the efforts of Holly and Jay's follow-up and other people who may use this information to actually use organizations within the state where we as consumers are going to be visiting every day to see that information. Am I clear?
I could not agree more. Could not. All right. I think we've given the marching orders. Thank you. All righty then. Norm, we are on to the Virginia Center for Public Health Informatics.
No, before that, Madam Chair, we'd like to just brief you on our transformation project. This is, Dr. Jang had alluded to the fact that we, at the last board meeting, said that we wanted to utilize the funding from CRF, and particularly the ARPA funding, to really begin a process for transforming public health going forward. And we've enlisted the services of Deloitte to help us in this process, and I'd like for them to give a brief briefing to the board about what is happening. And from Deloitte, we have Rana Sen, who will be giving that presentation.
Perfect. Thank you.
Thank you, Dr. Oliver and Madam Chair. This is Rana Sen. Can you hear me okay?
Yes, we can.
Thank you for the opportunity. I lead our engagement with VDH in this regard, and I'm grateful to spend some time with you right now. Provide, if you can just go to the next slide, provide a briefing of the work that we have embarked on. There are sort of two or maybe three parts to the conversation. One is I'll provide the construct of how we are proceeding with this effort. My colleague, Dr. Randy Gordon, is also on the phone, who would also speak to some of the content that we are able to gather in terms of input from various stakeholders. And then we will briefly cover next steps and open it up to questions and comments from you all. With that, Randy, if you can hear me, do you want to just introduce yourself briefly as well?
Yes, thank you, Rana. So, Randy Gordon, and I am at Deloitte, been part of Deloitte for 16 years now. Used to be at the Virginia Department of Health back in the late 90s, and been working with Rana on this project. And our goal here is to assist you guys, meaning the Department of Health and the Commonwealth in general, to transform public health in the next few years. And we've seen some of the challenges and opportunities that we face. And so we're going to explain how we're supporting this effort and some of the expected outcomes.
Thank you, Randy. Next slide, please. And if you do hear some barking in the background. Please excuse me. We have a puppy and who at the most critical times, decide to express herself quite loudly. So sorry about that. As Dr. Oliver mentioned earlier, we started this journey with VDH a few weeks ago. And the context of this is really the pandemic situation over the last 16 months and the efforts thereof, while has been heroic, has also been challenging on multiple fronts, has exposed some opportunities that are and need to be explored. And also combining that with the availability of the bolus of funding from various federal grants and some state fiscal funds opportunities, now is the time to engage a broad number of stakeholders across various entities for public health writ large across the Commonwealth. And using again the imperative around the funding is the exercise that we are working on. We also had the opportunity to speak with a few of you in the last couple of weeks through the facilitation that was done by Joe Hilbert. And as we are looking to develop the overall set of aspirations, we are also teasing out some key initiatives, to Dr. Zheng's point earlier, so that those can then be presented again back to the stakeholders and building upon that consensus. Ownerships obviously would be assigned, and ultimately the work products that we will deliver are twofold. Number one is the transformation roadmap, looking ahead through to 2025, and charters for some of the key initiatives based on the pathways that would be selected for transformation. Next slide, please. The three constructs that we have to guide us and engage with during this exercise are what you see on this particular slide. We have a steering committee that is chaired by Secretary Carey from Health and Human Resources. Commissioner Storen is the vice chair, and Commissioner Oliver, as the lead of the Transformation Task Force, is also on the steering committee, along with few other members from various organizations across the Commonwealth. We also have organized and facilitated 2 leadership labs where we invited again various members of the community and other organizations. Randy is going to speak about the outcome of those labs shortly. And we have an additional opportunity to engage with other stakeholders through what we call focus groups. And we're going to get into those details a little bit as well, so that we are able to help ensure that we are providing all of the different platforms for stakeholder input as much as we can within, of course, the time frame that we have been given by Dr. Oliver and his leadership team. Next slide. The first steering committee was held a few weeks ago now, and we had some really encouraging and thoughtful discussion based on sort of 3 questions. One was around top priorities. Second, what are some of the key challenges or barriers to those priorities? And 3 would be, what would be some of the enabling mechanisms to achieve those priorities? And the excuse me, the input at a high level that we received from the steering committee focused on, number one, the necessity of having an ecosystem approach, that this obviously with VDH in a leadership role as they're serving along with all of you and the other organizations does require the participation of different stakeholders. Equity along with the ecosystem engagement is another core concept that should be infused in all of the activities and also in the outcomes to be achieved. There was a healthy discussion on how social determinants of health should be incorporated as some of the outcomes as well, and how these attributes should also be part of the definition of the activities moving forward. The ecosystem topic that I just covered obviously implicitly includes the collaboration and the partnerships as well. And at the other key concept was the need for enhanced infrastructure. You know, we have defined sort of 6 broad pillars with data and technology, workforce, organization, public engagement and communication, and hard assets and facilities as those 6, some of which you all also had some meaningful conversations earlier today during this meeting as well. Some of the additional considerations that came to fore during the discussion also was the significant amount of not just the investment that is needed, but the sustainable aspect of it, along with the consideration of mental health, given again how challenged and tired the workforce is today, given the pressures over the last 16-18 months. Climate change was obviously another priority that was identified as a key element of how we should think about the future and the impact of climate change on public health, along with criminal justice and issues of public safety. And then lastly, the other key consideration was around this notion of having a 360 view of the resident of the Commonwealth and integrating the care delivery system so that this aspect of a holistic approach for the individual is considered as we look ahead. Next slide. So at this point in time, I would request Randy to provide some insight around the Leadership Lab and some of the content generated thereof. Randy?
Hi, Rana. Can you hear me okay, everybody?
Yes.
Great, thank you. So we have had at this point 2 labs, and they have been very well attended, and the participants have been very engaged. And the participants have consisted of folks from the agency, VDH, as well as across health and human resources agencies. And Dr. Carey has led those labs with Dr. Oliver as well. And the first lab really focused on the future state aspiration. Our goal here is not to change the overall mission of public health, which is really to assure environments in which people can be healthy, but to think about what public health should look like in the Commonwealth, given its mission, what it should look like 5 years down the road, and what it can look like. And we're at this inflection point in public health where, fortunately, we have received a substantial amount of funding, and most of this has been through the feds, but also through the state. in recognition of some of the areas that need to be strengthened in public health. And of course, COVID has pressure tested our public health system, has shown where it needs to be strengthened. And so the idea with the Future State Lab was to create this aspirational vision for public health in the Commonwealth. And then the second lab took that vision and said, given the what does public health look like, or what should it look like in 5 years in the Commonwealth? How do we get there? And the way we get there is by creating various initiatives and projects to strengthen the overall public health system in the Commonwealth. And we just completed that lab this week. We talked about 20 initiatives and prioritized those. And we're taking that input, and we will be using that input to feed into the overall roadmap for the Commonwealth for public health as one of the outputs of this process. We will have a third lab on data and technology, because we think that data and technology has come so far, and it has a lot to contribute to public health. It's not the answer, it's an enabler, but it needs to be key to what we do in public health. And most of the public health systems, both in the Commonwealth and across the country, need to be upgraded and updated to take full advantage of all the opportunities and capabilities we have through the advanced data and technology system that the rest of the economy and the world is experiencing. So if we can move to the next slide, please. The first lab, as I mentioned, was focused on the aspirational vision for public health in the Commonwealth. And these were the themes that came out. We took all the comments. We had a number of exercises to stimulate thinking and brought in a lot of experiences from across the country and really across the globe to stimulate some of that thinking. And I'm not going to read each one of these, but you can see them. And we've already touched on some of these, and how the vision is to improve, increase, and take advantage of the opportunities that we see before us. The ecosystem and partnerships, we know that public health agencies, the local public health agencies and the central office cannot accomplish the overall goal of public health without partnerships in the private sector, partnerships with other governmental agencies, and partnerships with other non-governmental organizations. And so one of the themes here is around continuing to build out and strengthen that ecosystem and partnership. I spoke briefly about technology and data. More to come on that. I think this is a huge theme that we need to explore and need to put together a very comprehensive technology and data plan for the public health system within the Commonwealth. We've already talked a lot today about communications. I think we realize the importance of communication, not just in communicating information, but also in establishing the authority, trust, and brand of public health and of the department. We've seen nationally where the trust in public health is not what it could be or should be in time of crisis, and certainly in time when we're not in crisis. Workforce, all agencies, I think, are experiencing this workforce crisis. We're seeing it in the private sector as well as in the governmental sector, but this has been a chronic problem with public health. And we are seeing the potential for a continued increase in retirements and folks moving out of public health. We need to reinvigorate our public health workforce and to resupply, if you will, the workforce. Equity is a theme that runs throughout public health, and the equity lens needs to apply to everything that we do, and we need to be very specific about how we are going to reduce health disparities and how all the services that we provide in public health are going to target especially those most vulnerable in our Commonwealth. Funding, obviously we can't achieve our potential without sustainable and significant and necessary funding. And then finally, policy development has been a core function of public health and will continue to be, and continuing to work through policies, both governmental and other policies, is going to be an important way that we move forward in the future. So that's the first lab recap. Next slide, please. And then, as I mentioned, we did have the second lab this week. We are digesting the output from that, and it really has helped us see a lot of the priorities. And I'll just give you a little preview. Funding and the role of public health in what we call the social determinants of health, which are poverty, economics, housing, other, rose to the top as priorities for the future for public health in the Commonwealth, and others as well. We will be able to provide more details on that as we go forward. The other input Rana mentioned, obviously, is getting data from specific interviews and from focus groups. And so we will be conducting 4 focus groups over the next couple of weeks. And we have about 60 people so far lined up to attend those focus groups. And we have supplied a number of examples of groups, not individuals, but examples of who will be in those focus groups from an organizational perspective. And then the next slide, please. And this is our last slide. We'll throw it open for discussion at this point. As Rana mentioned, the outputs of all this will be towards the end of October, but we do have some midterm outputs to help the department with thinking about the upcoming legislative and budgetary sessions in this month, actually, where we need to get some work forward to help inform the
Randy, we lost you.
Thank you. I got muted. Sorry about that. I was unmuted again. The ultimate output is this roadmap for 2025. That will be a comprehensive roadmap looking at public health in the Commonwealth, not just the department, but of course the department will be a central feature of that roadmap. And then we are also going to put together a number of charters for these initiatives that we've been discussing. And that will inform the roadmap and also be a work plan, if you will, for moving these things forward. So what I like to do at this point, depending on timing, is to get some feedback, both from what Ron and I presented, as well as we would like, you can either put it in the chat or you can raise your hand. We'd like to hear perhaps top 3 ideas you might have for the transformation of public health in Virginia. And again, we're looking at this as transformational, not incremental change. So with that, I will throw it open, and those who would like to talk, please raise your hand or put something in the chat box. So we really appreciate all the work that you guys do as well, because we know how important it is to provide this input to the department.
Hats and hands.
I've just got a question regarding your first substantive slide, the ecosystem engagement overview. What do you see as the role of the members of the Board of Health or the board in the aggregate in this process?
It was a bit hard to hear, but I think the question was what the role of the board or the board members would be in the process.
Yes.
Okay. Yeah. I think absolutely we would like the input. I believe, and I don't have the names handy on, right away, but we were able to schedule some time with 3 or 4 of the board members thus far. This obviously is another engagement in regard to getting your top ideas, and we also would like to continue getting some of your input and insights on an ongoing basis through the next few weeks as we look into creating this roadmap as Randy described as well.
In that regard, could you or maybe Joe send us email addresses for Rana and Randy?
Yes, we can get those email addresses to you. And we'll make them available to the board members. We could probably just drop them in the chat as well.
Yeah, should I provide the email addresses, Dr. Oliver?
Yes, please.
Okay, I'll put that in the chat. And I also see a question over here around, do we have information about other states? Are there 1 or 2 states that have already transformed public health? So we have done a fair amount of scan around what's happening in the country, and a few other research elements around global agencies as well. And what we have discovered thus far is while there might be few states who have made some progress on few dimensions, but what Virginia has embarked on, I'm looking at it comprehensively, is somewhat unprecedented in our scan thus far. For example, Dr. Oliver had mentioned it to us, and we followed up on this. State of Washington has done a fair amount of work around creating sustainable funding streams with their state legislature, if you will, over the next 4 years. So that's a model that we have identified as well, and hopefully that would be part of the activity moving forward in Virginia as well. So we are looking at some of these areas of work across various agencies and bringing them to the discussion. Randy, Dr. Oliver, anything else to add to that?
I agree with you, Rana. I don't think anybody's comprehensively transformed themselves, though a lot of states are beginning to do that. And so we're bringing those efforts to Virginia, and they come from a number of states. Washington, as Rana mentioned, there are a number of states that are trying some other things in Massachusetts and New York, and so we will bring those experiences. But I think our primary source of transformation is going to be from within the Commonwealth, and not just the department, but all the stakeholders that we've mentioned. And so we are looking at other states in addition, and also international, but we want to inform and stimulate as much creativity and innovation as we can.
I will just remind you quickly that not everyone is attending the meeting virtually. And for those of us who aren't, the link in the chat may not be particularly helpful. So I'm just going to ask Joe to make sure, or Alex to make sure, that the rest of us are copied on that email. And I also am aware that those of you who are on WebEx are having at least a fairly easy time hearing everything that's being said. That's not quite the case in the room. So sometimes we're going to have to stop and ask for repeat, because I think some of us missed some of those last comments. Are there any other questions about the study or the report? Linda? On the technology and data, will there be any consideration for a statewide health information exchange that goes beyond the all-payers claims database that would actually have outcomes and information that can be exchanged and easily accessible by providers?
Yes, one of the initiatives that we have identified related to data and technology is a comprehensive data exchange platform. The manifestation of this initiative obviously might take few different forms. Health information exchange obviously is one platform in that regard, but certainly the concept that is implicit in that, in regard to, number one, getting data from various sources for that comprehensive and holistic view of the individual is important. Two, how do you make data interoperable so that, again, the semantics of the data can be made consistent and analyzed, is the second attribute. And third, of course, is to make sure that the necessary privacy security considerations are applied, but also the ongoing aspect of data updates are considered in this exercise also as well. So there are obviously various other attributes, but I just want to highlight a few key ones.
Other questions or comments? All right, well, seeing none, I just want to say that we're grateful for your time and the attention to this project, and thank you for being with us this morning. The next item on the agenda is the regulatory update. And I'm sorry, I either want to put informatics in front of everybody or skip them all together. So our next item is informatics. Who is presenting?
Thank you all, and then we will say goodbye to you as well, but thanks for the opportunity.
Thanks for being here.
Take care, everybody. Thank you. Bye.
All right. I believe that I'm up next in that case if we're going to pursue the informatics update. Can everyone hear me? Thank you. Great. So good morning, everyone, members of the board. I'd like to take a few minutes to orient you to the VDH's new Center for Public Health Informatics that was established by Dr. Oliver earlier this year. Next slide, please. So before we go too far, I just really wanted to take the opportunity to level set on what informatics is, because I think that it really does mean a lot of different things to different people. These descriptions of informatics are provided by the Public Health Informatics Institute, which really is recognized as the informational group that helps steer informatics agendas across the country. All states interact with them as they're going through their planning and implementation for transformation and evolution with data and systems. So recognizing that it can be the process by which raw data is turned into information and subsequently knowledge, effective use of information and information technology to improve population health outcomes. It's necessary to maintain a robust health system and empower disease interventions and prevention. It's the cementing agent between public health and healthcare, and it is also innovation. So really, it covers a huge array of topical areas. Ones that I know that Rana has just discussed some of the concept, the importance of, as we think about these transformations of VDH into our next form. Next slide, please. So this is the mission of the center. It's to support programs through the provision of expertise in the development, translation, visualization, and dissemination of public health data and informatics knowledge to improve population health outcomes. So while that has a lot of area that it covers, the core focus is to really ensure that VDH and the VDH workforce have the knowledge, skills, and abilities to be able to use our data effectively across all of the various programs we possess, and help to ensure that we evolve to a place where we're able to integrate our data from those various systems to help arrive at that point that Rana just mentioned a few moments ago, of being able really to see the whole person, because we touch people in a number of different aspects of our organization, yet we have really no ability to see a whole person or look at them longitudinally. So that's one of our big objectives here. Next slide, please. So our current structure is a small one. You have myself, Tim Powell. I'm the director of the center. For those of you I haven't had the pleasure of meeting before, I've been with VDH for a number of years now. I've worked as an applied epidemiologist for about 20 years at this point in almost every aspect of our organization. And over the past 10 years have spent the majority of my time focused on informatics activities and improving some of the ways we're able to use our data. My colleague, Anup Srikumar, is my technical liaison to our Office of Information Management. Anup has a robust background in data management, both in the private sector and over the past 5 years that he's been with us here at VDH. So together we are working currently with an advisory council comprised of representatives from every one of our offices in central office, in addition to 2 representatives from our local health districts. That latter one is something that we potentially will see grow in the future. However, right now with the impact on the health districts in responding to COVID, there really just isn't the capacity to try to be more inclusive. I think it would just be detrimental to them at this point. The engagement with this advisory council is really to work through some understanding of needs above and beyond the assessments that we will talk about in a few moments, but to serve as a sounding board as we present the concept of new technologies and new solutions to ensure that it's going to align with those needs across the agency. We are also in the process of adding some additional staff to the center to help fill some identified gaps already. A lot of that is really around ensuring our workforce has the skills to utilize the technologies that we already have today. So we're adding a fair number of training resources to help address what we know factually as of today. Next slide, please. So you've heard a lot about the money that's leading to transformation in public health. I was going to spend just a couple of moments because, or painting a little bit of the background more clearly, because it really, we've recognized for many years that public health has not been funded well. We are not current in technology. And in 2019, a large initiative, the Data Elemental Health Initiative, was presented to Congress with this objective of having $1 billion allocated to the public health space by 2030. Monies were appropriated at the end of 2019. At that point, it was 50 million that was going to be made as a bolus to public health, centric on data, centric on the systems, but that 50 million was going across CDC and all the state and jurisdictional health departments. Even still, it was viewed as a huge, huge bolus for us. Next slide, please. However, as you have all heard now multiple times this morning, an abundance of monies have been made available to public health as a result of the pandemic. Through this and through even that initial 50 million that was appropriated, the CDC has established the Data Modernization Initiative, and this is a national, every state is receiving funds under the Data Modernization Initiative. And there are a number of expectations for every state to be responding to the activities that have been identified by the CDC at this point. You can see the vision of this overall initiative, though, is world-class data and analytics, in order to better inform and empower everyone, really, to be able to respond to the impacts of health in the United States. This has meant that VDH is receiving monies through some of our existing grant pathways. A lot of the associated activities are on planning and ensuring that we have assessments, comprehensive assessments across the enterprise to be able to, and in this case, in conjunction with the work of the Commissioner's leadership team and Deloitte work, identify that roadmap that's going to allow us to achieve that state of maturity. Next slide, please. So currently, these are the areas that have been identified. So this data modernization funding came into reality last year. I think nationally, not a lot occurred with it because everyone was.
What you're saying. Can you back up a little bit?
Yes. How far back do I need to go? All right. I'm not sure how far back I need to go. Can everyone else hear me okay?
I think it's, first of all, I think if you could just start at the beginning of this slide, and I think the people who are online can hear you perfectly well. For the people in the room, we're a little in and out, so we're going to try to cue you in when we don't hear you.
Totally acceptable. And so, it is actually hard to hear you as well. So I think we're both impeded by technology in this case. So this slide is presenting the areas of focus based on the Data Modernization Initiative grant, which are in complete alignment with the mission of the Center for Public Health Informatics. So we are looking at ensuring we have a skilled workforce, and this is thinking about those data and technology areas. We're ensuring that we will have systems that are interoperable and meet our operational needs, not today, but in the future. And then addressing data modernization from the concept of the data itself. And we'll talk about each of these in the following 3 slides. So next slide, please. So with regard to the skilled workforce, we are conducting assessments currently to understand the existing strengths and gaps that we have within our workforce related to their ability to utilize data. There's a big emphasis today on data science, which as a discipline, which has not existed previously really within the public health space. Very well recognized in the private sector industries, but really just emerging within the public health and public side of industry. So we're trying to figure out what we have and what we do not have. We have already, though, implemented some enterprise level training platforms to help close gaps and just add overall depth to our workforce. These training platforms focus on analytics and on those data science skills, in addition to the informatics skills that are necessary to ensure that we're able to do our modernization activities from a technology perspective. Additionally, we're working on developing partnerships with academia in order to support those applied skills that we have prospectively. Some may be aware, but the federal government has made a grant available to academic institutions to develop curriculum to supplement or increase the workforce available to work in technology and informatics in public health. And so we have partnered with 3 academic institutions who are applying for this grant. The outcome of that, should any of them receive that grant, will be that we will be able to work with them in establishing those curriculums and also to provide a pathway for internship opportunities so that those looking to get a degree in public health informatics and technology are able to understand what that environment looks like before they complete that degree. So they're more able to enter into this this workspace with the skills and an understanding of what's required. So next slide, please. So thinking about the systems and interoperability, while we are obviously doing a lot of planning right now towards the VDH 2025 vision, we already know that we have to migrate to cloud environments in order to ensure that our systems have the scalability that's necessary, as well as the flexibility that's required in order to ensure that we have that interoperability regardless of our system. This is an area that we know today we have some systems that have strong interoperability capabilities and others which have next to none. And so we're really looking at how we can ensure that those gaps are closed. Additionally, working on the expansion of a service-oriented architecture. And what these 2 bullets that you're seeing here are just 2 examples of what that service-oriented architecture relates to. One, being that we will assure that all person-level data will be geocoded regardless of the system, because this has been a gap that we have not necessarily had. We had some systems where it was occurring, so we are better able to identify really where events are occurring, and others that wasn't. And we have now the infrastructure to support this as a service for every system we have, so we're looking at getting that implemented. Additionally, the development of a master person index. This is something that, again, is very well recognized within the private sector. It's that mechanism by which you're able to understand how the people you engage with, we don't always call people by the same name, or people don't call themselves by the same name, but this will allow us to look at the same person from various systems and ensure that we identify them as the same person. So we are already underway, collaborating with the Chief Data Officer on this, of developing this framework. Additionally, the last bullet on here is really critical for VDH and really public health overall, remaining a key integrated partner with the healthcare systems around us. The Centers for Medicaid and Medicare Services mandated a couple of years ago that all the electronic health record systems will be FHIR compatible. Public health has not had that mandate yet, but if we wish to stay able to communicate effectively with the healthcare system, we need to do this. So through the data modernization activities, in fact, they have targeted that our vital records systems will implement FHIR over the next couple of years. So, while we can plan, the feds are sort of pushing an agenda on us at the same time, but this is giving us the opportunity to really start to invest in staff training to ensure that we aren't chasing and learning how to be members of this interoperable community, but are right there at the table the whole way through the journey. Next slide, please. And then that overall concept of data monetization. And this is really centric within the VDH enterprise. We currently do not have a data inventory of all the assets that we possess as an agency. So we are working on that to get that comprehensive enterprise inventory put together. And as we compile that, we are going to be feeding that into our enterprise analytics platform that's now underway. While we've had many challenges with data associated with COVID over the past 18 months, we've actually been very successful relative to other jurisdictions, in so much as at the very beginning, we created an ad hoc data warehouse for all things COVID. So we have all COVID information in one single database repository. So we're going to use that as our initial use case to develop a more cloud-based environment so that we are able to sustain the high volumes of data flowing in, process it appropriately, catalog it appropriately, and make it available to everyone who has a need to use it, while applying an analytic tool layer on top of it to really help streamline the accessibility and usability of the data we have as a VDH as an enterprise. Additionally, the things that we have learned over the COVID response through the collaboration with the Chief Data Officer, we're looking to build on those, making even greater use of the Commonwealth's open data portal as a mechanism for sharing really all the data that we want to make available to the public. In addition to leveraging the CDO's data access portal, which is a trusted data exchange platform that we can utilize to share between the state agencies as well as with other partners. We currently use this platform to exchange data with some of our academic partners who are doing modeling for us. And this is really the way data needs to be exchanged, really today and in the future. So we're going to be expanding the utilization of those. So in the few months that we've been in existence, this is where we're at. So if you have any questions, I welcome them.
I can go back to the recording if we want to hear more of it. I will open for questions, but I'll ask you to start with addressing Mary Margaret's question that's in the chat.
I am having a really hard time hearing you, unfortunately.
That makes two of it. Can you check the chat for, there's a question in the chat. Can you address that?
Yes, absolutely. And so is this related to the transformation question?
Yes.
Yeah, absolutely. Yeah, I agree. We absolutely do not want to be operating in a vacuum as we think about transformation. And to the comments made by Rana in the previous presentation, Deloitte and the commissioner's leadership team are working collaboratively with and looking across other jurisdictions. In conjunction, myself and within the center, I participate in an Informatics directors forum that's hosted by the Association of State and Territorial Health Officials, where the informatics directors for every jurisdiction come and collaborate and share status on both where we are today and what we see as the pathway into the future. One of the true benefits of this is that we're identifying area, everyone's sharing that same vision of sustainability. It's great to have a ton of money today and think that we can spend it, but if we can't sustain that infrastructure that we put in place, it's not worth that investment. And so we're trying to universally identify solutions that are going to be sustainable and help ensure that public health is able to achieve, the mission that it has, at least related to data and technology. So 100% not operating in isolation here.
Other questions, Jim?
This is an aggressive program. I think I understand that you're talking about getting someplace that incorporates all of this in 5 years. What are you going to do in the next year? There are only 2 of you. You can't do all of this at once. So how do you proceed a step at a time?
Yeah, absolutely. That's a fantastic question. And it's not just the 2 of us. So Anoop and myself work across the offices and we have a very, very high level of collaboration with our Office of Information Management, with our Office of Epidemia, really with all programs. And we're using that advisory council really as that key vehicle to ensure that we're sharing the common vision and understanding the challenges and accomplishing those steps that we've set out for ourselves. So to Dr. Oliver's vision, the center itself is not really intended as an office per se that's going to undertake an activity by itself and accomplish it independently. We are working as a facilitator across the entire organization, with those representatives from every aspect of the organization. So with regard the enterprise analytics platform, this is a collaboration of with that initial use case of COVID data, that it's a collaboration of the Office of Epidemiology, the Office of Information Management, the center, as well as others who are the stakeholders of those data. So it won't be us alone. And I know, to build on some of the other comments that have been made this morning, we're working on adding more warm bodies into our workforce to help ensure that we can meet the objectives that we're setting out for ourselves.
This is Wendy, may I ask a question?
Please.
Yes, you alluded to HL7 FHIR fire. Can you explain what that is, please?
Absolutely, I'd be happy to. So HL7 is the standards group that establishes how healthcare data should be structured in order to be shared with between organizations. And I mentioned that that CMS, the Centers for Medicaid and Medicare Services, have mandated that all electronic health record systems will have a FHIR interoperability layer available. Now, I apologize for not knowing the deadline for that off the top of my head, but it was a mandate as opposed to it was a will as opposed to a should. So all of the health space is working on the implementation of this at this point. What that equates to is a more automated manner of exchanging health data. So we want to ensure that while historically public health has had very, very specific definitions about how we need data to be configured in order to exchange it with us, this will provide us the opportunity to be a bit more broadly accepting of how we exchange data with the health systems and health care around us.
So is this a national, is this a?
Yes.
Can you define just a little more clearly what this is? Not is this a national program, organization?
It's actually
rec?
international. Yeah, so HL7 is an international organization that addresses health data exchange regardless of where you are. Every country in the world participates in this and sets those standards. And so what FHIR is a standard by which all those data can then be exchanged through, are you familiar with the term API? So API is an automated programming in an interface. It basically lets you set it up so machines can talk to one another more readily and transfer those data. Doesn't mean people aren't involved. There's always people involved to get the work done. But once we have this both national and international network of FHIR portals available, that exchange of data will become far more streamlined and dynamic. There was the comment in during the Deloitte presentation about the concepts of a more robust health information exchange. FHIR will be critical and elemental to an efficient and effective health information exchange, not just for VDH, but for healthcare overall.
Wendy, the bottom line here is HL7 is an international organization. It stands for Health Level 7 International Organization.
Got it now. Right. I just needed to know.
They came up with this. FHIR is Fast Healthcare Interoperability Resources.
Yes. Okay.
It's a standard. It's guidelines for how you should make things interoperable. And it's an international standard. EPIC, all your EHRs out there adhere to this. They must adhere to it.
Got it. Thank you.
We haven't even gotten an EHR yet. We're working on that. But we are also working to ensure that all of our data is interoperable, which means it has to adhere to this HL7 FHIR standard.
Okay. Thank you. Thank you very much.
Any other questions? All right, I thank you. We are running a little bit behind, so what I'm going to suggest is this. We go ahead and take our second break now. Grab your lunch, whatever you need to do, get back to the table, and we will ask Alex to do our regulatory update while we eat, and then we'll go right into the next presentation. Everybody good with that? Okay.
Is-
Don't deny me, sir. I'm really awful when I'm not in. Oh, okay, gotcha. Okay. Okay, gotcha. Yeah, I think we're quite good. Then how long is your drive home? Wow. Alex, I know you're not the cook, but this is not as billed. I'm actually fine, but I ordered cottage cheese as a side, and that'll take me right through. All right. Is everybody back? Okay. All right. The next item on our agenda is the regulatory action update. And Ms. Jansen, I am sorry to ask you to do this before you eat, but if you could.
Thank you, Madam Chair, members of the board. Can everybody hear me? All right. So I have up on the screen the regulatory action update for today's meeting. There are 22 pending actions under development, and you can see where they fall in terms of NOIRA's proposed actions, final actions, fast tracks, and emergency actions. There were two, can you scroll down just a little bit, John? There were two non-regulatory action items that have been taken by the Commissioner on behalf of the board since the June meeting, while the board was not in session. The first of these was, and you heard Dr. Oliver discuss this briefly during his Commissioner's report, the Public Health Order of Emergency requiring masks in K through 12 schools. During the General Assembly's 2021 Special Session 1, which is that continuation that we had earlier this year, Senate Bill 1303 passed, which required schools to adhere as much as possible to the recommendations of the CDC as far as transmission prevention. As cases of the Delta variant have increased and school boards have sought guidance, the Commissioner issued the public health order to require staff and students in all K through 12 schools to wear masks regardless of vaccination status to be in line with the CDC recommendations. The second of these actions that he took was to sign on behalf of the board the electronic participation in meetings policy. This policy is required in order for there to be virtual attendance as there is today. And so we needed to make sure that we had this signed. The chair had distributed this policy to the board members for any feedback, and no objections were received. And so the Commissioner was asked to sign the policy on behalf of the board. As we move towards the bottom of this page, you'll see we have 19 periodic reviews that are in process. As a reminder, we have to review all of our regulations at least once every 4 years. So these are the 19 that we have currently going on. And then at this last section here, you'll see the report summarizing the executive branch review that has occurred since the last board meeting. You'll see the work that has been completed by the Office of the Attorney General, the Department of Budget and Planning, the Secretary of Health and Human Resources, and the Governor. You separately, in your packets and also for those in the room in your binders, you also have a detailed spreadsheet that provides additional detail and information concerning all 22 of the pending items that are currently under development. And I also do just want to mention that I believe for those in the room, and we can put a link in the chat for those who are attending virtually, there are some frequently asked questions that were just updated for that public health emergency order regarding masking in K through 12 schools, and so we'll make sure that we have those available to you. Joe, can I ask Mr. Hopler if he has anything to add?
No, I don't.
Okay. All right.
So Ms. Hines has a question, and after that, anybody else who has one can either let us know through the chat or just speak up if you need to. Go ahead, Linda.
Has Commissioner Oliver taken any action on behalf of the board for the doula certification regulation that we were looking at the last meeting?
For the referring to the doula certification?
Yes.
That, Madam Chair, that action has been sent to Dr. Oliver, I think just yesterday, for his review and approval. So it's en route.
Are there other questions, Jim?
This is a bit embarrassing. You said there are 19 regulations in process for review. How many different sets do we have to review in the aggregate?
I believe the number is either 63 or 68.
So I don't, yeah, that's a great question, Jim, and I don't think that there's any board in the state of Virginia that has as many regulations as this one does.
Not surprised.
Nope. Are there any other questions?
Madam Chair, I see Dr. Klein has her hand raised. I'm not sure if that's a question for this section.
Wendy, do you have a question?
I do not. How do I unraise my hand? Let me work on that.
If you click the hand again, it'll unraise itself. Thank you.
I want you all to imagine what it's like to teach 20 college freshmen using this methodology every day. All right. Alex, thank you so very much. If we could move on to our special presentation today on Housing and Health by Pamela Kessner, the Chief Deputy of the Department of Housing and Community Development. Where is Ms. Kessner?
I am here. Good afternoon, everyone.
Hi.
Hi. So I believe they're going to share a PowerPoint that I forwarded. So while it's being pulled up, just a little bit of background. I am Pam Kessner. I serve as Chief Deputy with the Virginia Department of Housing and Community Development. There we go. I assume everyone can hear me?
Yes, thank you.
Okay, great. So thank you again for the opportunity to present before the Board of Health this afternoon. I was really excited when I was invited to talk about the intersection between housing and health. Never before has this topic been more poignant. We were focused on this pre-pandemic, but the pandemic really drove home, pun intended, the need to really focus on this intersection. So next slide. The department that I work with, in case you're not familiar with the Department of Housing and Community Development, we are our mission is to create safe, affordable, and prosperous communities to live, work, and do business in the Commonwealth. Today's presentation, though, I'll be focused primarily on affordable housing, on our homelessness, rent relief issues that I did want to share that do impact households staying housed and staying safe, as well as want to share what's happening across state agencies and secretariats as we work together on the intersection between housing and health. Next slide. So I'm sure you all are familiar with the social determinants of health, and housing is one of those social determinants. Pre-pandemic, we had been focused on raising awareness that in order for people to focus on getting an education, getting trained, finding a job, keeping a job, as well as addressing any type of health issues, it's critical to have access to stable housing and to be able to afford that. And we know that pre-pandemic, that there have been significant racial inequities in accessing both housing and health. And once the pandemic began, it exacerbated those inequities and made it even more challenging to reach communities of color and groups that have historically been having difficulties accessing both housing and health services. So when the pandemic began and the governor issued his stay-at-home order, it really elevated the need for safe, affordable, and stable housing. During the pandemic, I participated on a national webinar around the inequities in housing, as well as its impact on the health of individuals. And one of the speakers made this comment, this quote. It appears on the slide, and she said, "When America catches cold, communities of color catch pneumonia." And that really resonated with me because we know that before the pandemic, that communities of color were really struggling to pay for housing, to find jobs with a living wage, and to maintain good health. So while the pandemic has been just a horrific experience for us as a state, as a nation, as you know, globally, it has a few silver linings to the cloud, including raising the awareness that stable housing and access to health care are critical. Next slide. So again, pre-pandemic, we began working across state agencies to address the housing needs of specific populations. About 2011, 2012, the Governor's Coordinating Council on Homelessness began meeting, developed a strategic plan, and started working on reducing and hopefully ending homelessness here in the Commonwealth. One of the populations that the strategic plan focuses on are individuals who are chronically homeless, which means they go in and out of homelessness due to having chronic health, whether it's physical health issues or behavioral health issues, and have a difficult time paying for housing. So the Coordinating Council is an initiative that was led and continues to be led by the Governor's Office. It's co-chaired by the Secretary of Health and Human Resources and the Secretary of Commerce and Trade. Then right on the heels of the Governor's Coordinating Council, the Department of Justice entered into an agreement with the Commonwealth of Virginia to address the need to better integrate individuals with intellectual and other developmental disabilities. So the second block you see on this slide, housing and supportive services, this initiative got started in around 2012, 2013. The Department of Behavioral Health and Developmental Services is the state agency that was leading the effort, but began to pull other agencies together to look at how we in the Commonwealth could increase housing options for people with intellectual and other developmental disabilities. Then in 2017, the General Assembly tasked the Department of Housing and Community Development, the organization I work for, to create more permanent supportive housing for people who are seriously mentally ill. And again, that meant pulling together not only stakeholders, but our state partners in agencies, as well as across the secretariats. So we identified permanent supportive housing as the common thread when working with the homeless population, with the population who have developmental disabilities, as well as people who are seriously mentally ill. We wanted to align those efforts to ensure that we make best use of the resources we were getting from a variety of sources, as well as to create plans that would reinforce one another and not work at cross purposes. Next slide. The state agencies involved are listed here. It looks like alphabet soup. So for those of you that may not be familiar, of course, top of the list is the Department of Health, then the Department of Behavioral Health and Developmental Services, Department of Medical Assistance Services, Department for Aging and Rehabilitative Services, Department of Social Services, Department of Veteran Services, DHCD, our agency, Department of Housing Community Development, and lastly, Virginia Housing, which technically is not a state agency, but does work with all of us in the state to create more affordable housing in Virginia. They're basically our finance agency for housing. The priority populations, as I mentioned in the previous slide, are listed here on the right. And I did want to mention that as time has gone on, particularly over the past year or so, we've started to broaden our focus, but at the same time, we need to keep that laser focus on these populations while at the same time identifying the broader population that need access to stable and affordable housing. Next slide. Each of the state agencies involved have been identifying ways internally as well as externally to ensure that we, at this intersection of housing and health, that we identify resources that we can bring to the table, as well as identifying strategies that work to address the housing needs of populations that I've mentioned earlier. One of our, a piece of the structure is an interagency leadership team. This leadership team is composed of state agency heads, so that we have the leadership of all of the agencies that I listed earlier at the table and helping guide the work of the agencies. We have a permanent supportive housing steering committee that meets on a monthly basis. Pre-pandemic, we were actually meeting every other week because of the significant amount of work that we were focused on. And while that work continues, we've had to limit our meetings to once a month and ensure that we incorporate the work around responding to the pandemic, as well as our ongoing work of creating more permanent supportive housing for the populations I mentioned earlier. Also, we have action plans specifically for each of the populations that we have prioritized, and we work in updating those plans and assuring that our work across state agencies align. I also wanted to mention that both the Department of Behavioral Health and Developmental Services and the Department of Medical Assistance Services, DMAS, have created specific staff positions that focus on housing. Because they noted the need to do more concentrated effort in the area of housing so that their agencies are part of the housing conversation. We've learned bringing housers together with social services organizations that we all have our own jargon. And so it's important that we have internal liaisons within agencies that can help share the understanding between housing and health. Next slide. So I wanted to share a few details, specific details of some of the agencies related or that are involved in our statewide efforts to align our housing and health work. DMAS, as many of you probably know, was approved to receive a 1115 waiver, and they now call it the High Needs Support Benefit. This benefit, while not in place yet, will be coming in place next year. Later in the year, I believe. It will provide housing and employment services for individuals with behavioral health and complex medical needs. It will also help the state to scale up supportive housing and supportive employment programs by leveraging additional federal dollars. DMAS is working with managed care organizations to advance the social determinants of health-related activities for housing, employment, and food security, and is also working on a regional basis with and local coordination with their MCOs to ensure that their members have access to available housing and support services. The MCOs recognize that stable housing means that their members will have more success in addressing chronic health problems. Next slide, please. The Department of Behavioral Health and Developmental Services, I mentioned their focus on the IDDD population, intellectually disabled and developmentally disabled population. They have a state rental assistance program that the General Assembly has funded over the past several years in order to provide permanent supportive housing to vulnerable populations like the IDD population, or like people who are experiencing chronic homelessness or people with serious mental illness, there are 3 components to permanent supportive housing. The rental assistance is key. Many times these individuals either have lower paying jobs or can't hold a job because of their disability. So they need rental assistance. But the other 2 legs of the stool, if you will, include capital to pay for the creation of housing. And then the 3rd leg is supportive services. And DMAS helps pay for the supportive services. Department of Behavioral Health here has the state rental assistance program, and they are looking, working with us, the second bullet, to use some of their resources along with ours at DHCD to create more permanent supportive housing projects, creating new developments that would include PSH units, and our funds would be used to help with pre-development activities for housing developers. Department of Behavioral Health is also working in communities to bring housing developers together with community services boards. In fact, they had a webinar yesterday bringing together those 2 groups. It's difficult when you bring 2 systems together like housing and health, because again, we talk different languages, we have different skill sets and knowledge. And so it's critical that we build bridges between these 2 systems so that they can work together to create more housing for those communities, those populations that are most vulnerable. And lastly, during this past special session of the General Assembly, the legislators identified $5 million to create more permanent supportive housing units, specifically in Northern Virginia, to address the state hospital bed crisis. This money was ARPA money, the money coming from the federal government related to the pandemic. And you all are probably familiar with many of the state hospitals. They have no open beds, which means individuals out in the community that need to be hospitalized have no place to go. Yet there are some people within these state hospitals that are able to go back into the community. However, there's no housing available. So this $5 million will be used to help create more permanent supportive housing units, specifically in the Northern Virginia region, so that they can move those individuals who can return to the community, opening up beds for individuals that need to be hospitalized. Next slide. This slide is shared with our agency as well as Virginia Housing. So I'm going to start with Virginia Housing at the bottom of the slide. As I mentioned, Virginia Housing is our state housing finance agency. You all may be more familiar with VHDA. That's their old name, Virginia Housing Development Authority. They now go by Virginia Housing. But they oversee the low-income housing tax credit program. And several years ago, they incorporated into this program that any developer accessing these tax credits must provide at least 10% of the units be offered to the priority populations I mentioned earlier. So this has been critical to incentivize more housing being created for people with special needs. And our agency, I've listed 3 items here, and there's a 4th that I'll add that I neglected to put up here. But the first I just want to mention is our Housing Trust Fund. We have been very fortunate over the past couple of years that the governor and the General Assembly has significantly increased the amount of funding in our Housing Trust Fund Just 3 years ago, it was at 7 million statewide for this program, and we're now at 55 million because of the significant need to create more affordable housing as well as to address homelessness. The Housing Trust Fund is in the code. It states that 80% of the fund is used to create or preserve additional affordable housing, and then up to 20% of the funds are used to address homelessness in Virginia. The second program, and I'm going to go into more detail about this one, is our lead hazard reduction program. We work very closely with VDH on this program, but besides having affordable and stable housing, it's critical that the housing that people live in, especially families with young children, that they are lead-free and are healthy. And I'll talk more about that in just a couple of minutes. The third program there, I will also go into more detail further in my presentation, but the Virginia Rent Relief Program was stood up specifically to keep people housed during the pandemic so that they stay safe and prevent either transferring the virus or getting the virus. And a fourth bullet that I should have included, I was remiss, but it's our broadband program. And I wanted to share this with you because it's going to have a significant impact on all sorts of issues, including telehealth and telemedicine. Our agency, DHCD, during the special session, received from the Governor and the General Assembly $700 million of ARPA funds to build out the broadband across the state so that it will be available to all, regardless of where you live or your income. So, for example, in rural areas, it's hard to get broadband to rural communities or homes that are located off main highways. And in urban areas, it's very difficult for many families to afford broadband or the internet. So this program will address both, getting broadband to all areas of the state, as well as helping families and households pay for the broadband. Next slide. So this is where you can go to the next slide. I want to talk about the healthy housing. Next slide. The lead hazard, thank you. The lead hazard reduction program we first received funds from HUD, $5.6 million to specifically address lead, but 600,000 of those dollars will be focused on broader healthy homes supplemental funding, which can address other issues beyond lead, such as mold and mildew. We know that in Virginia, we have high rates of asthma in communities, and addressing mold and mildew is critical to the health of the children. In fact, some pediatricians are very frustrated at times when a parent comes in for their child to be treated for asthma or allergies, only to learn that the environment that the child is living in is exacerbating their health situation. And in many communities, there are not many other options for housing. The rental market is very tight right now, and accessing affordable rental property, rental units, very, very challenging. The lead reduction program offers remediation of lead-based paint hazards across the state. It's focused on households that are at 80% AMI. And it can be used whether you own your home or if you are a renter. The priority is to serve children with elevated blood lead levels. And lastly, again, during the general session, the General Assembly's special session, the governor and legislature allocated DHCD for this current fiscal year, $3.75 million in ARPA money. And then the following year, we'll receive another 3.75 for a total of $7.5 million to expand this lead program and to be much more flexible. The HUD lead program tends to have more constraints, and our goal is to use the ARPA money to reach more households and provide additional services related to a healthy home, which leads me to the next slide, where HUD has provided a list of 8 principles that basically are standardized principles of a healthy home. And you see them there. You know, they need to be dry, clean, safe, well ventilated, pest-free, contaminant-free, and well maintained, as well as thermally controlled. So these are the guiding principles when we look at a healthy home, that we'll be using the ARPA funds to ensure that homes, especially homes with children, meet these 8 principles. Next slide. So I want to conclude my remarks with the Virginia Rent Relief Program. And while this isn't specifically related to housing and health, it again was stood up last year, the Rent Relief Program, at the request of the governor, so that we could avoid households from being evicted because they could not pay their rent due to either a loss of job or a loss of hours or increased expenses related to having to have tutors come in or childcare expenses because children weren't in school, parents were working from home. There are all sorts of reasons why people could not pay their rent due to the pandemic. So the program was designed specifically to stabilize housing, keep people housed, as well as make landlords whole. There are 2 entry points into the program, one for landlord and one for tenants. And some landlords have multiple units, so the landlords are applying for rent relief for more than one of their tenants, which helps streamline the program. Regardless of which door you enter, if you're a landlord or if you're a tenant, they still have to work together in order to access these funds. And the same information and documentation is needed from both parties. They have to sign an agreement. We're currently utilizing federal dollars through the Emergency Rental Assistance Program. The first tranche of these funds, we've received $525 million. A second tranche will follow at about $466 million. So we'll have over $1 billion available to help people stay housed by paying their rent. And we pay rent at this point in time directly to the landlord. This last bullet identifies 2 communities in Virginia that receive a direct payment of ERA funds, Chesterfield and Fairfax counties. They chose to administer their own programs. So we do not serve those 2 counties, but we do direct people to how to access those services in those 2 communities. Next slide, please. So since June of last year, we have distributed over $377 million statewide, assisting nearly 50,000 households with rent payments. And we still have $700 million available, so please spread the word. We know that there's been a lot of confusion because of the different eviction moratoria that have been placed by the CDC. But luckily here in Virginia, we don't have to depend on the CDC or the federal government for protections of tenants. during the special session of the General Assembly. Excuse me, the governor and the General Assembly. I'm going to take a sip of water. Included in their budget language that landlords have to work with tenants to apply for rental assistance before the landlord can seek an eviction. So it doesn't matter whether or not a CDC moratorium is in place. This protection is in place in Virginia through June of 2022. So hopefully we'll be able to serve even more landlords and tenants to ensure they do not get evicted and disrupt their home lives, which can be very traumatic and very costly for landlords. Next slide, please. Wanted to include some links to this program, the Rent Relief Program, in case in your networks you would like to share. If you would like any type of specific outreach or presentations made, please let me know. On my last slide, I have listed my name and contact information. We also have an outreach and engagement grant through a nonprofit that has 12 other sub-grantees across the state doing targeted outreach to communities of color, to communities where households may not speak English, may not have access to the internet, or who may be very hesitant to reach out to a government agency for help because they're not documented. We do not require that tenants have to be documented. So there's my contact information, and I'd be happy to answer any questions if there's time.
Up on screen or in the chat. So we're going to go with Holly, Jim, and then whoever comes next. Thank you very much for your talk. It was very informative. I wondered what happens to those funds if the dollars are not used. We've gotten a lot of federal dollars, and it looks like you're working hard to get them spent. But what happens to the funding when or if they're not spent?
So fortunately, Virginia, we are basically the highest performing state in the nation for getting the funds out. The Treasury, the U.S. Department of Treasury required states to spend 65 or obligate 65% of their allocated amount by the end of September, and we will meet that. So we will continue to spend those funds, and that's for ERA 1. We're told that some states who may not be able to use all of their ERA funds will come to us, or other states that have a good spending rate. We have till September 2025 to spend the second tranche, ERA 2, which should kick in towards the end of this month. So that's at, I think I mentioned, $466 million. And so we'll have time to spend those dollars. If by chance the amount or the request to provide rental assistance starts going down, we can shift over and help people who need to find another place to live. So for example, while landlords are prohibited from evicting a tenant right now in Virginia for lack of payment of rent, the landlord could choose not to renew the lease at the end of the lease, which is legal. And we've heard that some landlords are starting to do that for a variety of reasons. So we could use some of our second tranche of ERA funds to help relocate households, help pay for their deposits. We could even pay some of their back rent to clear their credit history. So That's our strategy as it relates to the funding. Did that answer your question?
Public disclosure, I'm an affordable housing developer. I use VHDA, Virginia Housing Allocations. I'm just so glad that the link between housing necessities and public health has finally been recognized. That 5 years ago, that wasn't the question. It was not an issue. Now it is, and that's wonderful. Around the Commonwealth, and especially in Northern Virginia, there are tens of thousands of households who are housing cost burdened, meaning that they spend more than 50% of their income paying rent. And that burden doesn't seem to be recognized in your priorities. And I recognize that priorities are priorities, but the scale of the problem for very low-income households is really serious. And I would hope that would be a continuing discussion point among the people participating in this in these programs. One of the issues for us that will become, unfortunately, increasingly problematic is the number of adults who have serious problems that don't require institutionalization, but require case management at a level that simply isn't available now. Young adults and adults with autism, and on the serious end of the spectrum, young people coming out of foster care for the first time and living independently, and people with all levels of disabilities. At some point, we're going to have to provide funding for the services for those people to live independently in a way that matters. As a landlord, we're doing what we can do, but it's inevitable that there are problems when case management is not adequate to deal with individual needs, and that's just a reality of it. Which leads me, I guess, to my last point, which is resources. Never enough. The Virginia Housing Trust Fund is bigger than it's ever been. The $55 million is terrific. Seems like a lot of money. Northern Virginia's multiple jurisdictions receive maybe 10 or 12 million of that. That's just a drop in the bucket. It's nice to talk about. It beats the heck out of nothing, but it isn't going to get any significant number of units produced. And that's just I guess what I'm doing is advocating for continued efforts to get more resources pumped into the system if we really want to deal effectively with the needs. Anyway, I've ranted on long enough. Thank you.
Well, thank you. I just wanted to quickly respond. Our Housing Trust Fund, through our Affordable and Special Needs Housing Program, specifically focuses on households of greatest need. We have funds both at state and federal level, home money, as well as the National Housing Trust Fund that provides funds for households at 30% or less AMI, which are those households you had mentioned. So this presentation specifically, I focused on the housing and health intersection, but we are focused on those areas as well. We actually have a pilot program going on right now on stabilizing housing for young adults who have aged out of foster care, which is another group you mentioned. So we are working on that. And we have now started receiving significant amounts of funds through our housing innovation and energy efficiency program. I won't go into great detail, but it's specifically focused on energy efficiency. We're receiving about $21 million per quarter to put into affordable housing to lower the costs of energy for households at 80% or below AMI. So we have other initiatives going on. I'd be happy to talk with you offline if you'd like to learn more, but I do appreciate your comments. You're right on target. Totally agree.
Thank you.
Other questions? Benita.
Thank you so much for your presentation. I learned a lot. And I was wondering, do you work with community organizations like, for example, here in Richmond, there's Rework Richmond and Peter Paul Development Center, places like that, on local levels, or?
So how we work with those organizations, we'll have grant funds, for example, through our homelessness prevention efforts and homelessness intervention efforts. We provide funding through the continuum of care. So here in Richmond area, Homeward is the lead, and that continuum of care determines how they want to prioritize funding. So we do funnel funds to other nonprofits across the Commonwealth, including here in Richmond. So we have, I'm not sure if we have any funds going into the two that you had mentioned, but we do get funds to local nonprofits as well.
Other questions? I'm just going to add one very quick one because we are losing our quorum just after 2, and I want to be mindful of our time. When you listed the attributes of a healthy home, one of them was not that the house was connected to utilities. Why is that?
Not sure. These were the 8 principles that HUD provided. So it could be HUD is assuming that households would be connected to utilities, but that certainly would be something that if we went into a home and they didn't have access to running water, for example, that would be something that we would identify resources to assist the household in getting running water, for example. But yes, utilities, it just wasn't included, I guess, in HUD's list, but that is an area that DHCD, we do help people get connected to water through our community development block grant, as well as we have the indoor plumbing program, IPR. So we have other ways to connect households to resources other than what's listed on those 8 principles. Thank you. Good question. Yeah.
All right. Thank you for your time. I want to move us along here in the interest of getting as much work done as we can today. Because I know some of our public speakers are talking about our two regulatory action items, or our first 2. I'm going to take public comment at this point. Ms. Jansen, how many people do we have signed up?
We have 3 people signed up to speak.
2?
3.
3 people. Okay. Well, in that case, can we call our first folks? And I will remind everyone that we have approximately 2 minutes per speaker, and since we have only 3 speakers, I don't see that as a problem. So, who is first?
Absolutely, Madam Chair. So there are 3 persons signed up to speak today. I'll be calling 2 names at a time. The first name is the person who will speak, and the second is the person on deck to speak next. Pursuant to the public participation policy, each speaker will have a maximum of 2 minutes in which to speak. If the 2-minute period ends while the person is speaking, we will allow the speaker to finish that sentence, after which they will be muted, and I will call the name of the next speaker. The first speaker is going to be Brent Rawlings, and the on-deck speaker will be Kristen Party. And there is a timer on the screen to help, and we'll start that as soon as you start speaking.
Good afternoon, Madam Chair, members of the board, and Brent Rawlings of the Virginia Hospital and Healthcare Association. Really here today just to say thank you. One of the items on your agenda, I'm speaking to the regulations of the patient-level data system. This was on your agenda, you may recall, at your last meeting. When we saw the agenda posted and the draft regulations, we reached out immediately to the Department of Health to alert them to some concerns we had, and you all were kind enough to postpone that to this meeting today. The main issue we had was the regulations as drafted created a conflict with the National Uniform Billing Codes. That would have created quite a bit of trouble for us with claims submission and payment and other things that we do in our hospital operations. So we quickly worked with VDH, Joe Hubbard in particular, and DHI to find an alternative, found an alternative code field and codes to use. We believe this meets the intent and the actual requirements of the budget, as well as comporting with the National Uniform Billing Code. So again, just wanted to thank you for your grace in that. And we do support those regulations as they've been redrafted. Thank you.
Thank you.
Thank you. The next speaker is a virtual speaker, and it is Kristen Pardee. And then the third person who is now on deck is Heidi Dix, who is also going to be a virtual speaker. So I'm going to unmute you now, Ms. Pardee, and then you can start speaking.
Good afternoon. Thank you so much. My name is Kristen Pardee with the Pharmaceutical Research and Manufacturers of America. I want to first also thank you. We did submit comments back in May and really appreciate that many of them were addressed in this current draft. I did want to bring up a couple of issues where we would seek further clarification. Most of them probably seem fairly technical, but they would do a great deal to helping with consistency and accuracy. The first is in the section on definitions. There is a definition of discount, which goes beyond the scope of the term traditionally. It includes two terms, which is consumer coupons and copay assistance. And while these are things that really assist the patient in paying, they do not actually impact what we would consider a discount, because the point of the legislation is to give a line of sight into what the payer's costs are. And so we would request that those terms be removed from the definition for consistency. The second is in the definition of the term launched. To bring it more in line with the traditional understanding of launched, we would request that there would be a stipulation that it's when it's first made available for sale in Virginia, as well as removal of the word acquired, because this isn't a typically defined term and can cause confusion. And finally, in price, the legislation itself uses the wholesale acquisition costs throughout the entire statute. And price is really a term that goes towards insurance benefit design. So we don't believe it's appropriate here. There are also several elements in the data element chart that were not included in the statute that we believe should be removed to be consistent, as well as some clarification on the terminology and the reporting requirements for manufacturers. We will follow up with written comments, as I see my time is up right now. Thank you.
Thank you. Thank you.
I was able to glean about maybe half of what she said. I'm sure it's significant information. Maybe when the regulations that she is addressing come up for consideration, maybe we can identify the things that she was particularly concerned about.
Absolutely, and we're going to switch the order and take that one first anyway. So. Okay. All right. Our next speaker will be Heidi Dix. I'm going to unmute you now so you can begin speaking.
Good afternoon. My name is Heidi Dix. I'm the Deputy Commissioner for Quality Assurance and Government Relations at the Department of Behavioral Health and Developmental Services. We request your support today to amend the patient-level data system, requiring inpatient hospitals to report the legal status of any individuals meeting the criteria for voluntary or involuntary psychiatric commitment. Information reported by inpatient hospitals to the patient-level data system does not currently include information regarding the voluntary or involuntary psychiatric commitment status of minors or adults. Changes to the system to identify the type of admission for children and adults is a small change that will give us additional data and information to work collaboratively with our community partners and stakeholders to develop solutions to this ongoing problem we have with our state hospital census. Thanks.
Thank you. Right. Okay. Madam Chair, this concludes the list of individuals who had signed up to speak. With that, I will close the public comment period, and we will move on to our regulatory action items. I'm going to switch the order of these just a little bit. I believe we will get through the first two at least before we lose our quorum, but I know a number of people are here for the prescription drug transparency regulations, so I'm going to move that one first if Rebecca's here. And she is. And Madam Chair, before she starts, she is called in so that she can have audio through there so that we can hear her very clearly in here, and also folks online can also hear her. So I'm going to mute the room mic just so everyone is aware. Okay.
Okay, there we go. All right, Madam Chair. Can we test it again? Oh. Okay, can someone on the call indicate whether or not that they can hear me? I think Robin Kersey can see if you could nod and confirm.
We can hear you now without echo.
All right, excellent. Excellent, all right. With all those technical difficulties. Madam Chair, I am Rebecca Allen, the Senior Policy Analyst for the Office of Licensure and Certification. I am here to present a combined emergency regulatory action and notice of intended regulatory action, or NOIRA, for the promulgation of 12 VAC 5-219 Prescription Drug Price Transparency Regulation. The documents pertaining to this regulatory action were previously provided to you and can be displayed on the screen if you have any questions. Chapter 304 of the 2021 Acts of Assembly Special Session 1 created Code of Virginia section numbers 32.1-23.4, 38.2-3407.15:6, 38.2-3407.22, 54.1-3436.1, and 54.1-3442.02. Collectively, these new statutory provisions create a new reporting mandate involving prescription drug pricing for health insurance carriers, pharmacy benefit managers, manufacturers, and wholesale distributors. The data collection will be done through Virginia Health Information, or VHI, which is a nonprofit data services organization contracted to VDH for a number of different health data reporting functions. Any adjudication under the Administrative Process Act for compliance failures will remain the responsibility of VDH. The Legislative Act also requires the creation of regulations for these reporting requirements within 280 days of enactment, which necessitates the use of a combined emergency regulatory action and NOIRA to meet that deadline. Because data collection on prescription drug pricing is a new responsibility for VDH, we are proposing the creation of a new chapter of regulations, which will be 12 VAC 5-219, as no other regulatory chapter that is currently in existence is an appropriate fit. This new regulatory chapter would have 14 sections separated into 3 parts, which I will now summarize. Sections 10 through 40 comprise Part 1, which are the general information requirements for the chapter pertaining to the overall administration of the program. Section 10, definitions, defines the terms used throughout the regulation. There are several terms that were already defined in statute, so those terms are defined by cross-referencing the relevant statutory provision. Section 20, registration, specifies the contact information to be provided by the reporting entities, the obligation to update their contact information, and what reporting obligations a reporting entity has if it closes, discontinues operations, or is acquired. Section 30, notice. This section specifies the manner in which VHI and VDH will contact a reporting entity and provide notice if VHI accepts an alternate drug group system other than Metaspan. It also specifies that the obligation for VHI to turn over relevant records upon request. Section 40, allowable variances, authorizes the State Health Commissioner to grant, modify, or rescind variances, otherwise known as waivers, to the reporting requirements found in Part 2. It also explains the variance process such as how a request may be initiated, what to include in the request, and that a response to the variance request will be in writing. Sections 50 through 90 comprise Part 2, which are the reporting requirements for each entity. Section 10 is carrier reporting requirements. This restates the minimum reporting requirements for carriers that are set in Code of Virginia, Section 38.2-3407.15:6. There is a table included that details the names and definitions of the data fields that carriers will be completing when they report to VHI. Section 60, pharmacy benefit manager reporting requirements. This section, similar to the one for carriers, restates the minimum reporting requirements for pharmacy benefit managers, PBMs, that are set in Code of Virginia, Section 38.2-3407.15:6. Similarly, there is a table included that details the names and definitions of the data fields that PBMs will be completing when they report to VHI. Section 70, manufacturer reporting requirements, restates the minimum reporting requirements for manufacturers that are set in Code of Virginia, Section 54.1-3442.02. There is a table included that details the names and definitions of the data fields that manufacturers will be completing when they report to VHI. Section 80, wholesale distributor reporting requirements. This also restates the minimum reporting requirements for wholesale distributors that are set in Code of Virginia, Section 54.1-3436.1. I will note, wholesale distributors are not required to report annually like the other ones are, but only upon a determination that data received from carriers, PBMs, and manufacturers is insufficient. This section explains the process by which VDH and VHI will inform wholesale distributors that their obligation to report has been triggered. There's a table included that details the names and definitions of the data fields that wholesale distributors will be completing when and if they report to VHI. Section 90, method of report submission. This section directs the reporting entities to provide their data to VHI in conformity with the format and file specifications. If the reporting method changes, VHI is required to provide notice to all the reporting entities at least 30 days in advance. Part 3 of the chapter addresses enforcement of these regulatory requirements. It is subdivided into two articles. The first article, which is sections 100 and 110, deals with the validation and auditing of the data reported, and the second article, which contains sections 120 through 140, addresses the administrative due process owed to a reporting entity if VDH determines that enforcement action should be taken. So starting with Article 1 in Part 3, Section 100, data validation, notification, response. This section lays out the steps and timeline for VHI to validate that the data received is complete and how a reporting entity may correct its reporting if VHI does identify errors. This section also outlines the consequences of failing to correct and how VHI will hand off that matter to VDH for enforcement. Section 110, audit, corrective action plan. This section explains the ability of VHI to audit the data received for accuracy and how a reporting entity may correct its reporting if VHI does identify errors. These provisions addressing data audits are required to be included in the regulations. This section also outlines the consequences of failing to correct and how VHI will hand off the matter to VDH for enforcement. Now on to Article 2 in Part 3. Section 120, disciplinary action. This section makes clear that violations of the regulations are not permitted and what the actions are available to the State Health Commissioner if violations occur. Section 130, civil penalty. This section outlines the civil penalty schedule, which is required by statute to be included in the regulations. The civil penalties increase based on how long a reporting entity remains out of compliance and how frequently a reporting entity has violated the reporting requirements. This section also specifies when civil penalties start to accumulate, when payment is due, how payment is to be made, and the financial consequences of not timely paying a civil penalty. These financial consequences are set in the Code of Virginia, so the inclusion of that information in the regulation is to ensure reporting entities are fully apprised. Section 140, Informal Fact-Finding Proceeding. This section lets reporting entities know how they can contest a civil penalty and the process by which to ask for an informal fact-finding proceeding. The section also explains how the occurrence of an informal fact-finding proceeding impacts the civil penalty due date and late fees. Should the board approve this combined emergency regulatory action and NOIRA, they will be submitted for executive branch review, which includes review by the Office of the Attorney General, review by the Department of Planning and Budget, review by the Secretary of Health and Human Resources, and review by the Governor's Office. After completion of the executive branch review, the combined emergency regulatory action and NOIRA will be submitted to the Virginia Register of Regulations via regulatory town hall. As soon as it is submitted, the regulation will become effective. This is prior to any public comment period being held, but please note that VDH staff have met with stakeholders and the National Academy for State Health Policy during the development of this regulation and have given them the opportunity to comment on the draft. VDH did incorporate feedback received into the emergency regulatory action before you today. This combined emergency regulatory action and NOIRA will be published in the Virginia Register of Regulations for a 30-day public comment period to begin upon publication. After conclusion of this public comment period, the regulatory action will continue forward with the usual stages of a standard regulatory action, which means a proposed stage and a final stage. These stages will be brought before this board at future meetings. The emergency regulation will remain in effect for 18 months while a permanent replacement regulation is being developed. In the event we do need additional time, we can seek written approval from the governor to extend the duration of the emergency regulation for up to 6 additional months for a total of 24 months or 2 years. Madam Chair, I recommend that the board approve this combined emergency regulatory action and NOIRA for the promulgation of the prescription drug price transparency regulation. And Alex, you're going to have to unmute and all that.
Nothing in this particular piece of legislation or the regulations that talks about negotiating drug prices.
I know there are federal rules preventing the negotiation of drug prices, at least in some contexts, and I was wondering if Virginia has more flexibility than that.
I'm not going to be able to answer that question. That might be something for the Office of the Attorney General to opine on.
I didn't hear any of what he said. I'm sorry.
It's all right. I'll take it, Robin.
Okay.
And Jim, I'm sorry. I don't know the answer to that question off the top of my head, so it's something we'll be happy to look into and address that. This is not our area of expertise. We'll consult with others in the office.
I'd be happy to, I mean, it would be wonderful if it were, in fact, some capacity in Virginia to negotiate.
Yeah.
One more question. This seems to demand a lot of staff time. How many people in the Office of Licensure are going to be required to deal with oversight and enforcement?
So for the staff resources needed, the data reporting piece is going to be handled by VHI, so that's actually non-agency staff that would have to be handling that. For the enforcement piece of it, it is a little bit difficult to predict because we don't know how compliance is going to look, if we're going to have compliance failures, because we do allow for opportunity to correct reports if they are not complete or accurate, and it's only after a refusal or a failure to correct them that we would move on to adjudication. I believe that the fiscal impact that we reported to the General Assembly about this was that we would need at least one staff member who would handle the adjudication processing piece of it, though we already have staff at the agency who do informal fact-finding proceeding adjudications. We already have, I think, 2 hearing officers, Joe? Yeah. So we don't have to hire additional staff for that. It was just for more of the back end, you know, sending out the notices, assembling the case file. So we predicted that we would need 1 at this time.
It seems to me just reading the documentation that comes in the door is going to be a time-consuming process.
I want to be super mindful of the fact that we're going to lose our quorum before too long. Benita, can you guys online hear us at all? I'm getting a note that really you cannot. I know Stacy has a question, Benita has a question, so. Okay, do you have a comment? You do have a comment? Okay, then Stacy has a comment? A question? Stacy?
I'm coming. Sorry.
Okay.
Just an overall question, just for my clarification. Because this was passed by the Assembly, we have to pass emergency regulations by a certain date. But then also we're going to work to clarify with any public comment, go through the regular rulemaking process in conjunction with it, correct?
That is correct. So the emergency regulations will be published at the same time that the notice of intended regulatory action is, and that notice of intended regulatory action kicks off the standard regulatory process. So we are going to be developing permanent replacement regulations because the emergency regs can only last for so long.
Got you. Okay, because I give you a lot of credit because it's a very weedsy topic and intentionally confusing. So I think that there will be, it's a good infrastructure and a good basis for us to have. It is a really, I think, a good process. I think there needs to be more transparency across the spectrum. But I'm sure as we go through the rulemaking process, there might be some ins and outs of what would be the most useful to us might get a little clarified along the way.
Okay. Other questions or comments? All right, Alex, I'll ask for you to call the roll, and then I will also ask for Michael Sarkisian to be on deck for the next presentation.
All right. Mr. Kreitzer?
Yes.
Thank you. I know Mr. East is not with us. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison? We may have lost her. Yep, we lost her. Dr. Zhang?
Yes.
Thank you. Dr. Kinzer? Lost her. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Pirritz? Yes. Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell? All right. And Ms. Whipple? Ms. Whipple, you're on mute.
Yes.
I'm sorry, I know you unmuted.
Okay, I'll try again. I vote yes.
Thank you very much. Madam Chair, the vote is 11 for the motion.
All right, and so the motion passes. And now we will very quickly move on to regulations of the patient-level data system. Mr. Sarkisian.
Good afternoon, Madam Chair. I am Mike Sarkisian, the Director of Data and Quality for the Office of Information Management. I'm here to present a combined emergency regulatory action and notice of intended regulatory action, NOIRA, for the amendment of 12 VAC 5-217 regulations of the patient-level data system. The documents pertaining to this regulatory action were previously provided to you and can be displayed on the screen if you have any questions. Virginia's patient-level data system administered by Virginia Health Information Incorporated on behalf of the Public Board of Health is a data set that is updated by each inpatient hospital in the Commonwealth of Virginia every calendar quarter. Section 32.1 Code of Virginia requires that every inpatient hospital shall submit to the board patient-level data where applicable and included on standard claim forms. The data included in this data set is comprised of a series of data points including specifically identifiable information, hospital name, attending and other physician name, payer, employer, patient, patient demographics including sex, race, address, date of birth, employment status, inpatient status, and birth weight information, admission-related information such as the admission type, admission source, date and hour, and diagnosis code, and other information including the discharge date, total diagnosis codes, any external causes of injury, existence of untreated comorbidities, up to 6 total procedure codes, revenue, service, and service charges up to 23 of each, and total charges grouped by revenue category or HICPIX code. I apologize, I do not recall what that acronym stands for. These data are used for a variety of purposes, including analysis of utilization planning and quality improvement by hospitals, insurers, physicians, and Department of Health.
The purpose of this regulatory action is to conform the regulations to the provisions of Item 307 D1 of the 2021 Appropriation Act. This item requires inpatient hospitals to report the admission source of any individuals meeting the criteria for voluntary or involuntary psychiatric commitment as outlined in subsections 16.1-338, 16.1-339, 16.1-340.1, 16.1-345, 37.2-805, 37.2-809, or 37.2-904 of the Code of Virginia to the patient-level data system. These data are required to be shared with the Department of Behavioral Health and Developmental Services through the addition of a new legal status field in the data system. Collecting this information in the patient-level data system will better enable DBHDS to study the distribution of involuntary psychiatric admissions throughout the community hospital system with a goal of developing strategies to alleviate the high census at state psychiatric hospitals. This regulatory action adds a new reporting requirement for inpatient hospitals titled Legal Status as applied to voluntary or involuntary psychiatric admissions of minors and adults. As proposed in this regulatory action, there would be 7 different types of legal status reported. Parental admission of minors under the age of 14 and non-objecting minors ages 14 or older. Parental admission of objecting minors 14 years of age or older. Involuntary TDO of a minor. Involuntary commitment of a minor. Voluntary admission of an adult. Involuntary TDO of an adult, or sexually violent predators, whether prisoners or defendants. VDH worked closely with the Virginia Hospital and Healthcare Association, DBHDS, and VHI in preparing this regulatory action.
You're good.
Should the board approve this combined emergency regulatory action and NOIRA, they will be submitted for executive branch review, which includes review by the Office of the Attorney General, review by the Department of Planning and Budget, review by the Secretary of Health and Human Resources, and review by the Governor's Office. After completion of the executive branch review, the combined emergency regulatory action and NOIRA will be submitted to the Virginia Register of Regulations via regulatory town hall. As soon as the regulatory action is submitted, the regulation will become effective immediately. This is prior to any public comment period being held, but please note that VDH staff have met with stakeholders and the National Academy for State Health Policy during the development of this regulation and gave them the opportunity to comment on the draft. VDH did incorporate feedback received into the emergency regulatory action before you today. This combined emergency regulatory action and NOIRA will be published in the Virginia Register of Regulations for a 30-day comment period to begin upon publication. After conclusion of this public comment period, the regulatory action will continue forward with the usual stages of standard regulatory action, which means a proposed stage and a final stage. These stages will be brought before this board at future meetings. The emergency regulation will remain in effect for 18 months while a permanent replacement regulation is being developed. In the event we need additional time, we can seek written approval from the governor to extend the duration of the emergency regulation for up to 6 additional months for a total duration of 24 months or 2 years. In conclusion, Madam Chair, I recommend that the board approve this combined emergency regulatory action and NOIA for the amendment of the regulations of the patient-level data system.
Thank you very much. So what I will need now is a motion to approve regulatory action item 12 VAC 5-217. I have a motion and a second from Holly. I'm sorry, the motion is from Dr. Schuler, and the second is from Holly. I'm sorry, that is so gendered, but I didn't mean it that way. Are there questions or comments? No. We'll ask, you said call the question, right? All right, so I will ask Alex to call the roll.
Absolutely. Thank you, Madam Chair. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmonton?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison, was she able to rejoin us? No. Dr. Jang?
Yes.
Thank you. Dr. Kinzer? Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Pierce? Thank you. Dr. Schuler? Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell is not back with us. And Ms. Whipple?
Yes.
Thank you. Madam Chair, there are 11 votes for the motion.
All right, and the motion passes. Thank you very much. Dr. Schuler, do you need to leave us at this point, or do you have time for the next one? You're leaving? You stay for the next one? If you stay for the next one, I think we're good. All right, Lori, Falana, Dr. Falana. Dr. Pierce, I'm sorry. I was not being very respectful to call the woman by her first name and the man, and I was just having a senior moment. I said Dr. Schuler and Holly, as though she was, is the light green? Good afternoon. Y'all ready? Yeah, can you just speak up a little bit for the people in the room? No problem. I think most of you know me. I'm Lori Solano. I'm the Deputy Director of the Office of Epidemiology at VDH, and I'm here to present some proposed amendments to our disease reporting and control regulations. So throughout the COVID-19 pandemic, I think you know that timely and accurate reporting of cases and laboratory test results has been critical to ensure a rapid and complete public health response. In March of 2020, the federal government enacted the Coronavirus Aid, Relief, and Economic Security Act, or CARES. This law includes a requirement to report COVID-19 data until the end of the declared emergency by the federal government. Subsequent to that, VDH implemented an emergency regulation in January of 2021 to amend our disease reporting regulations to clarify who had the responsibility to report, the information required, and the means of reporting related to COVID-19. Those emergency amendments to the regulations are currently scheduled to expire on July 19th of 2022. So the action being presented is a proposed stage regulatory action to be promulgated within the Virginia Administrative Code to make certain COVID-19 case and laboratory disease reporting requirements permanent. The action presented today is intended to improve the ability of VDH to conduct surveillance and public health investigations, collect the needed public health information, and to continue to implement disease control measures for COVID-19. The changes will position the agency to better detect and respond to these illnesses to protect the health of the public.
The substantive changes from the current emergency regulation include the removal of the requirement to report negative COVID-19 tests, the removal of the requirement to report hospitalizations and ICU admissions through the Emergency Department Care Coordination Program, and the requirement to submit all COVID-19 laboratory reports electronically. Although reporting negative tests will no longer be required in Virginia, should the action move forward, it will still be required as long as the federal emergency is declared consistent with requirements in the CARES Act. VDH will also still receive information on hospitalizations and ICU admissions, but there will be no additional requirements on reporting entities. Consistent with the emergency regulation, this proposed action requires that all suspected or confirmed COVID-19 cases are submitted electronically. It clarifies that all entities that hold a CLIA certificate of waiver are required to report. It adds phone number, email address, and ethnicity to the list of fields to report, and it adds coronavirus severe to the list of infectious diseases that shall be reported to persons practicing funeral services. Should the board adopt the proposed amendments, they will be submitted to Virginia Regulatory Town Hall to initiate executive branch review, and that consists, of course, of review by the Office of the Attorney General, Department of Planning and Budget, Secretary of Health and Human Resources, and the Governor. Following approval by the Governor, they would be published in the Virginia Register of Regs for a 60-day public comment period, and then we would bring the final amendments back to the board for consideration at a future meeting. And that's all I have today.
Thank you very much. To get the ball rolling, I'll need a motion to approve Virginia Regulatory Action Item 12 VAC 5-90.
So moved.
All right, I have a motion by Ms. Hines. Now I need a second. Dr. Puritz, would that be you? That's a second by Dr. Puritz. All right, we have a motion and a second. Are there questions and or comments about this regulation process? Dr. Miller.
Well, just a quick question. What was the rationale for leaving out the two the two changes from emergency to permanent? It was reporting hospitalizations and then one other thing, and I'm having a senior moment. But what's the reason for leaving that out?
The hospitalizations and ICU?
Yeah.
So VDH is still working on being able to connect to the EDCC, which was the original plan for how we would obtain that information. And so while that language was included in the emergency reg, the link was never operationalized, and instead we obtained that information through case investigations and information from VHHA, the Hospital Association. So we plan to continue pursuing electronic means to obtain that information, but we didn't feel it was pertinent to include in this action, as ultimately it would be through connection with the healthcare system's electronic health records, and it wouldn't require any additional actions on their part. So we'll still receive the data through case investigations and VHHA data that's already shared with VHHA.
Okay, so you would still be collecting the information, it just wouldn't be in the regulation.
Yeah, VHHA collects it and shares what to date, and we also have hospitalization data from our case investigations. Even today online, you'll see when you go to our webpage, there's a link to VHHA's dashboard, but we also have VDH hospitalization data as well.
Mr. Edmondson?
I'm sorry, Dr. Peak, I'm still confused. In the text of your memorandum, it says that the regulation requires physicians and directors of facilities to report hospitalizations and ICUs, but didn't you just say that it isn't required?
So they would report that, and Robin might be okay, as part of our case investigation and patient information, but the previous emergency reg was that they do that they would report that specifically through the EDCC. That linkage has not been Emergency Department Care Coordination Program. That linkage from VDH to EDCC has not yet been operationalized.
So,
Not through that specific EDCC.
Are there other questions? All right, Ms. Jansen, I think we're ready for a roll call.
Absolutely. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. I know Ms. Harrison dropped off. Dr. Jang?
Yes.
Thank you. Dr. Kinzer also dropped off. Dr. Klein?
yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz? Yes. Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. And Ms. Whipple?
Yes.
Thank you. Madam Chair, the vote is 11 for the motion.
Okay, so motion passes.
Thank you.
We are now without a quorum. We had only one more item to go as it was, so we will continue on. We'll have a discussion of that item and all questions. We will just not vote on the item today, and then we'll have our presentations. But I'm going to ask that we just take a 5-minute facilities break because I need one. And we'll see you back here in just a second. All right. Dr. Gormley, I'm sorry that we've relegated you largely to discussion, but we're so grateful that you waited and that you're here. Come on down. I promise we will be timely with your concerns.
Okay. Geez, I watched everybody fail one night, and then they broke it. I was going to do this right.
There's no fail. There's only really successful and a little bit successful.
Okay, I'm looking for really successful. Madam Chair and members of the board, I'm Dr. Bill Gormley. I'm the Chief Medical Examiner for Virginia. I'm here today to present a proposal to increase the cremation fee that's charged by the Virginia Department of Health and the Office of Chief Medical Examiner. The documents pertaining to this are in your package. The current cremation authorization fee is $50 per decedent examined. The fee is to compensate the local medical examiner for the time spent to examine and document that this death requires no further investigation by the Office of Chief Medical Examiner, basically to ensure that it's not a medical examiner case or all the examination's been done. The local medical examiner reviews the death certificate, performs an external examination, and may need to review medical records or interview the certifier or other healthcare providers to assure that it's not a medical examiner before doing the authorization. The funeral service pays the $50 directly to the local medical examiner that performs this examination. According to Section 32.1-309.3, the Board of Health establishes a fee. This fee has not been increased since 1974, which was the year I entered medical school.
High school.
The cremation fee is a way to compensate those medical examiners who are actually appointed in accordance with 32.1-282 of the Code of Virginia. These are local medical examiners or private physicians, nurse practitioners, or physician's assistants that are in private practices, and the fee helps compensate them for the time that's spent to review these. These investigations could take any place from 15 minutes to over an hour, depending on the additional information that they require to make their assurance. So, and this fee is not commensurate with the work that's required or the revenue they would lose from time away from their practices. In many other systems, a medical examiner is only required to review the death certificate and maybe look at medical records before authorizing cremation. The fee for these types of reviews in the surrounding states varies from $50 to $200. In Washington, D.C., for example, the fee is $75. In Milwaukee, the medical examiner charges a $357 fee for a process similar to the Virginia thing, where we do an external examination as well. We're asking for a moderate increase in the fee to reflect the amount of time and resources required. Our proposal is to increase the fee to $100 to demonstrate that the Board of Health recognizes the value of our local medical examiners and their personal sacrifice, as well as to improve our ability to recruit and retain local medical examiners. This would assure that those services remain available in the communities in Virginia. We have had discussions with the three major funeral service organizations in Virginia. None are adamantly opposed to it. They did have a few questions and whines, mainly about why we need to do an external examination. and why it's required in people that die in hospitals. We do have data that external examination finds cases that we would otherwise miss, and of the cases that we have to reinvestigate and become cases, about 60 to 65% of those cases are hospital deaths. With that, Madam Chair, I recommend the board approve this when you have the opportunity.
Thank you very much, Dr. Gormley. I think what I want to reiterate for the rest of our board is that since we cannot conduct business today at any further point, what we can do is everything that we normally do besides make a motion and vote. I'm going to ask all of our questions, and of course, Dr. Oliver is empowered to take action on our behalf when the board is not in session. So what I would suggest is we get any concerns or questions we have out on the table so that he's fully aware of our feelings about this. And again, I extend to you our apologies and our gratitude for your coming. Do we have questions or comments, or it seems utterly reasonable?
Concerns. I mean, I think this is reasonable. The fee hasn't been changed, and I can't remember how many years.
Let's not do that.
Yeah. So no concerns.
Yeah. Any questions from anybody? Yeah. All fees get increased every 40 years. Yeah, exactly. This seems pretty straightforward. Thank you for your time.
Thank you.
I just want to point out I was a sophomore in high school when that was, that's terrifying. All right, so now we move on to our presentations, and Joe Hilbert has legislative, and then Joe and Stephanie have budget. Although I don't see Stephanie.
Madam Chair, what we're going to do is I'm going to ask Stephanie Gilliam to present this next item, which will be an update on the budget actions that were taken in a special session that just concluded.
Okay, good morning, Madam Chairwoman and members of the board. Can everybody hear me okay?
No, not in the room. Of course, that is not news. Try again.
Hello?
Hi, Stephanie. I think we might be able to hear you, but just go slowly because there's a lot of reverb in the physical room.
Understood. So today I'm going to walk you through the changes to VDH's budget from the GA Special Session 2 that were just approved by the governor on August 10th. Next slide. The main point of the special session was to determine how the state would utilize the over $4 billion in relief that was provided through the American Rescue Plan Act, or ARPA. The funding is known as the State and Local Recovery Fund, or SLRF. The funding is intended to support public health expenditures, address negative economic impacts, replace lost revenue, provide premium pay for essential workers, or invest in water, sewer, and broadband infrastructure. So according to guidance from the Treasury, the funds have to be obligated but not necessarily incurred by December 31st of 2024, but they have to be fully expensed by December 31st of 2026. The main reasoning there is to give time for those water, sewer, and broadband infrastructure projects to expense out, since they typically take a longer time frame. VDH received funds for several efforts, most of which require VDH to report back on a detailed plan on their use and implementation schedule by September 30th, so the end of this month. And then the first progress report is due on December 31st. So I'm gonna walk you through each of the buckets they've given us. On this slide, you can see we got $5.75 million in FY22 and an equal amount for the next biennium for well and septic system improvements. You can see they are for homeowners that are at or below that 200% of the poverty lines. Up next, they gave us $50 million this fiscal year and another $50 million in the next biennium for drinking water infrastructure, again targeting small and disadvantaged community waterworks.
And then last on here, we have $5 million this year and $5 million next biennium for substance abuse and suicide prevention efforts. Next slide. We've also received $8 million just this fiscal year to improve facilities' broadband connectivity and network issues. We received $10 million this fiscal year, and we'll receive $20 million for the next biennium for an electronic health record system. You may recall we've tried to pursue funding for that in the past, but we've never been able to attain it, so that's pretty exciting. We're actually going to get to move forward on that. Then the next one, we have $20 million in FY22 for facilities maintenance. And so that's a typo on there. Sorry, because there's a typo in the next one too. We have $10 million and $40 million in the next biennium for to modernize our information systems. Next slide. We also have $1 million for the creation of an oral health public task force. That's actually going to be a pass-through that will go to Catalyst, the Oral Health Coalition. Next, we have $10 million in FY22 and $20 million in the next biennium for a records management system. And then lastly, we have $20 million in FY22 to provide targeted community outreach in difficult-to-reach communities harmed by COVID-19. So in total, we've received nearly $300 million of the SLRF funds over that 3-year period. John, did you want to talk a little bit about how we're operationalizing the funds?
Sure. This is John Ringer with VDH. The way we're working with this is that we know that we have funds that we need to expend now, and we also have a lot of reporting requirements to the Governor's Office, the General Assembly. And so we partner with Deloitte. They're providing some project management services to us, because the other thing I want to say clearly is these are huge projects that we have 4 years to complete. And if we were not responding to COVID, this would be a big challenge for VDH. And while we're responding to COVID, this is a gigantic challenge for VDH. So we're partnering with Deloitte. They're helping us with project management so we can do the content work, and they can help with developing the plans and the reports based on our feedback and our discussions and stuff. So that's going to be a big help for us. The goal of all of these projects is to do it the right way, to take our time, to do the analysis, the research, and look at the data so that we can move forward with all of these in a manner where we're expending the funds wisely to get the maximum impact for VDH and the people of Virginia going forward.
Thank you, John. So next slide. So this last slide just relates to federal grants that VDH has received directly, but they're funded with that same ARPA funds dollars from that particular act. So due to certain entities' interpretation of language that was added to the budget during the previous General Assembly, the powers that be decided they would not administratively grant us the appropriation to utilize any of those grants that had those ARPA funds on them. The grants themselves were awarded to us as far back as like April, but they, for the most part, made us, wait until this process to give us the actual, spending authority. They have granted us appropriation that basically matches what we anticipate spending in FY22. Many of these awards you can see extend beyond, into the next biennium. So we're also going to seek appropriation for that, during this next session. And to explain the one note on this slide, they over-appropriated the last grant. You see there, the Disease Intervention Specialist Workforce Grant, but it's not really an issue since, we have what we need to utilize the current level of funds. And that's all, unless anyone has any questions.
I have a question. May I? This is Wendy Klein.
Yes, you may.
The genomic sequencing, which is so vital, relative to the other dollars that are on this budget, that seems like a relatively small amount. Is that, obviously you all think that's, those who prepared this budget find that adequate? Is that correct?
So again, these amounts weren't determined by our General Assembly. These are federal grants, in that case, the CDC. So that's the dollar amount that the CDC determined to give us for that function. Does that make sense?
It does.
Unhappily so. Are there other questions? Jim?
Hi, Alex. Could you put me up? Just need a red, no green.
I can't hear Jim.
I'm curious about the seeming overlap regarding the $30 million for LHD maintenance and the $20 billion for community outreach. How do you use money for local health department buildings to serve at-risk communities?
Stephanie, this is John. I'll answer that question. I think the difference is the maintenance money is literally for facilities maintenance. Many of our local health departments are, in rural areas, and the buildings need repair and maintenance. Some of them we actually need to relocate, and so that's what those dollars are for actual physical improvements. The outreach money is literally for population health work that is going to flow through the local health departments to community organizations and partners, specifically in parts of the state that have been hardest hit by COVID, to try to make a difference. And this is the kind of investment money that you, as a group, were asking for over the last year to specifically invest in, improvement of outcomes. Does that help?
All right, so the maintenance and, I guess, upgrade money it will be disproportionately targeted at counties or regions that are considered more at risk.
Yes.
Yeah. Okay. It's not just going to be allocated $300,000 or $300,000 per county or something like that. Okay. Gotcha. Okay.
Are there other questions?
I'm just curious as to the project management costs of Deloitte. What percentage of all of these dollars are going to Deloitte for project management?
That's a good question, and I do not know the answer yet, but I'm going to figure that out. The simple answer is that many of these projects are very straightforward. The drinking water, well water and septic improvements, the pass-through to the Oral Health Task Force, we could do those without a bunch of Deloitte support. But the work, the administrative systems improvements that we need to make inside the agency, or the records management project involves a lot of scanning and digitization of paper records and automation of processes and stuff. We're going to need more support in those areas. So I would say it's not an even percentage across every single individual project, that many of those projects there's going to be very little cost other than help preparing kind of the upfront plan, but some of those other projects, one of the projects on there is the electronic health records, and that's a huge lift for us, and it'd be a lot more work on that side than the other ones.
And is Deloitte just the de facto one that we use, or do we put this out for an RFP and have them have to competitively bid for different project management?
That's a good question. We did not do that. We were using Deloitte for some other project management as part of COVID response, and that's why we chose to use them for this.
Yeah, so I just worry about price tag, and I think that the board should be aware of that, and we should be aware that the monies are being spent appropriately. I think if a consultant is aware that there's no competition, I just get a little concerned about the price tag.
That's very fair, and again, we're going to be required to report on many of these quarterly to the governor and the General Assembly, and those are going to be public, and we're going to have to report the expenditures on that too. So whatever percentage that we pay them is going to have to be part of that public reporting. So we're concerned about that as well. But there's a concern that you just can't just ask one person to do it.
stopped working also.
Sure.
Sorry.
No, I hear you. So
Okay.
what you're saying is we can't be concerned and then not competitively bid it.
Exactly. To me, that's contradictory.
So I understand that. We're also in a situation where the emergency declaration is over. We can no longer do emergency procurement to write an RFP right now for project management for these. We're talking about 4 months before anything happened. And we have to report to the General Assembly on September 30th.
Okay.
With real stuff. So in that sense, we're working with what we have. So.
Okay, thank you. Are there any other questions for the presenters?
All right. Well, if not, then we're going to turn to Mr. Hilbert for the legislative update. Oh, do you want the mic back?
Madam Chair, members of the board, I'll be brief. I just wanted to give you an update on where we're at as an agency in terms of putting together some proposals for legislation for the next General Assembly session. We've been working on this internally for some time. A week or so ago, we submitted 9 proposals to the Secretary's office for them to look at and consider, and we're awaiting their feedback. Just wanted to give you a thumbnail sketch of each of these for your awareness. First is dealing with infection prevention in nursing homes. And the proposal would be to require that nursing homes who had more than 100 beds or who had ventilator service or hemodialysis service to require that they have a full-time infection preventionist, either under contract or on staff. This was a proposal that came jointly out of our Office of Epidemiology and Licensure and Certification. Another proposal that deals with access to drinking water. So in Virginia, most of the water systems that we have are very small number of connections. They don't have a lot of resources to make improvements, and many of these systems tend to serve populations that are vulnerable, disadvantaged in many ways. So we're proposing that a new fund be established in the Code of Virginia that would provide VDH with the resources to provide additional technical assistance and support to these small disadvantaged water systems. And that might include providing incentives for those water systems to be incorporated into larger, more financially stable systems. So we have this kind of packaged under the equity framework, because there is definitely an equity component to access to safe drinking water. So we are working on that. We have another proposal that would authorize the board here to establish licensure fees for nursing homes and hospitals through a regulatory process. You might have heard this in prior years. Right now, these licensure fees are set in the Code of Virginia. These particular fees have only been in place since 1979, not 1974. But it's a very small fee. We're looking to give the board the authority and the responsibility to set those fees at an appropriate level. We also have proposal right now, hospital emergency departments report do syndromic surveillance for us, and they report that to VDH on a voluntary basis. They all do it, but voluntarily. We're looking to make that a mandatory requirement. We also have a couple of proposals dealing with on-site septic systems and private wells.
we're looking to have a study resolution enacted by the General Assembly that would direct the Health Department to study the establishment of water quality standards for private wells. So right now, if you get your water through a public water system, like City of Richmond, there's extensive quality standards that have to be met. But if you get your water from a private well, there's no such requirement. So whenever one of these wells, whenever you sell a home, or anything like that, there's no requirement whatsoever for water testing or anything like that, other than when the well is first built, first dug.
We're looking to do more work on that. We also have a proposal dealing with septic systems in the eastern region of the state, specifically the eastern shore, the middle peninsula, and the northern neck. Right now, those localities are all subject to requirements of the Chesapeake Bay Preservation Act, and one of those requirements deals with having septic systems pumped out on a regular basis. And localities in those systems are required to monitor compliance with that. Our experience at the Health Department, we've studied this at the direction of the General Assembly. The localities are really not doing a good job of that. And that has some consequences for us in terms of our Chesapeake Bay compliance scores. The localities would like for VDH to take over responsibility for monitoring that. And we agree that that would be a good idea. It will be a big fiscal impact on the agency to do this. So we have a proposal in to do that. We're also working on an accompanying budget amendment request that would provide those local health departments with additional resources that would be needed to do this work because it is labor intensive. One or two more. Back in 2020, the General Assembly passed two different bills dealing with sexual assault prevention and treatment. And one bill put some training requirements on the health department for providing this type of training staff in hospital emergency departments. A different bill put similar requirements, similar training requirements on the Department of Criminal Justice Services. Ours is a completely unfunded mandate. It hasn't kicked in yet. We put a proposal in to consolidate those requirements with criminal justice. And we've had some initial reach outs to them to see if they're amenable to taking that on. We're still having those discussions. That's in as well. With some trepidation, we put in a requirement pertaining to a certificate of public need. So in 2020, the General Assembly passed a very large bill that was under the guise of COPN reform and consolidation and streamlining. It was a massive bill. They were moving lots of sections around, putting new stuff in. So, of course, in doing that, they made some mistakes, one of which was they inadvertently exempted the University of Virginia from COPN. And the other one was they have two contradictory requirements about the replacement of certain existing medical equipment. So we put in a proposal to correct those two things that we believe were inadvertent errors in drafting. And the only other one that I have on my list is dealing with genomic sequencing. And so this is obviously a new and emerging field, and our proposal would say that any lab that does this and then submits those results to the state lab, that they would need to be submitted electronically. So, Madam Chair, that's a thumbnail sketch of the 9 that we have. Again, we just submitted these about 10 days ago. These are being reviewed by the Secretary. We haven't gotten any questions yet. I know we will. We'll find out probably in the October timeframe which of these look like they're going to get the go-ahead to be introduced as bills. Happy to answer any questions. Yes.
The bill regarding the small community water work, is that dovetailed at all with this, well, $100 million over the next 3 years that for the from the ARPA fund, drinking water infrastructure and resources that is directed to small and disadvantaged community water work? Is that dovetailing with that at all, or is it?
We have a separate budget amendment. So you're looking at the money that we got through ARPA, right? So separate from that, we're now going through the process internally of developing our budget amendment requests for the general session, for the regular session in January. And as part of that, we have a separate budget amendment request of, I think, $1 million as seed money for this fund. There could still be some overlap, though, with the ARPA money, potentially.
The ARPA money is eligible for municipals to apply for now, if they need it.
Yes.
Okay. Jim?
The ARPA money is also, we're supposed to be sending that on specific projects. This fund is a little different in its scope. This could potentially, like I said, this could potentially, sometimes it might be that the best way to help a small water system is to make them part of a bigger water system, because they literally don't have really anything more than, they really don't have anything to it. It's amazing that it's still functioning, right? And that's where the real inequity comes in.
Jim?
I remember in our last meeting, we talked about doing some sort of an organizing effort to get board members in a position to be able to advocate for things that the department wants, and the big thing is money.
Mm-hmm.
I don't think anything has progressed in that regard, and I wonder, at least if it has, I'm not aware of it. What can we do? What should we do to help you get some of this stuff through the General Assembly?
Yeah, that's a great question, and you can definitely do a lot. You know, the ARPA stuff, it just moves so fast, and we wound up getting a large amount of money really pretty easy, honestly. What's our challenge now is to make that 3-year commitment in the ARPA money permanent. That's going to require a lot of advocacy. So I think what we can do, and we will do, is we will put together talking points and peg to the appropriate budget amendment or whatever, or bill or whatever it happens to be. We will share those with the board, and we will ask you to contact whomever you think, you know, we can give you suggestions.
Give us suggestions.
Yeah, absolutely.
Anybody else? Okay.
Oh dear, let me see.
Mary Margaret, is that you? Yes, no? Who is that? Are we done?
Her question was not answered.
Oh, she has a question in the chat. So, Joe, do you have these legislative proposals in written form, and can you share them with us?
Yeah, we can sharing with the board members.
So let me extend that suggestion. The next thing on our agenda is simply to ask you to review our meeting dates for next year, and then normally under other business, we would do member reports. I think it's become abundantly clear that we can't all hear each other, and member reports, honestly, it's very difficult for those of us in the room to hear the things that the folks on the WebEx are saying. So what I'm going to suggest is that if you have a member report that you would like to share with the rest of the group, please email those to me by close of business tomorrow, and I will send those out so that we're not constituting an illegal meeting. I will send those out as an informational item, or I could send them to Joe, and he could send them with the legislative update as well. Is that good with everybody? Sure. Yes, now's time. Yes, sir, we'd like to go home.
Yeah. For those of us concerned about women's health, yesterday was a momentous day, or 12:01 a.m. today was, and I asked Allison earlier, and she said she will explore this. I'm just wondering, given the Supreme Court's ruling, the 5-4 ruling that basically allows the Texas law to go into effect, at least for a while, if we could get something from the Attorney General or Allison in particular about the likely, if any, impact on Virginia women of that and the potential Mississippi issue, Mississippi law issue. It just, I don't know that it's there's anything that we can do, but I would like to be more informed about the issue than I am right now.
Very well. Linda? I was also wondering maybe in the next meeting if we could have an update from the Department of Health about the potential behavioral health crisis being created by the closure of state psychiatric hospitals. I'm sorry, I didn't hear the last thing you said. Potential behavioral health crisis that's being created by the closing of state psychiatric hospitals. Yeah. Yeah. All right. Is there anything else we need? Meeting. Okay. So yes, we can just real quick look at the meeting dates. I think they're pretty clear to everybody, but those are our meeting dates for 2022. If you'll just take note of those, they are also in your binder or your packet online, as it were. Thank you. Anything else from anybody else? All right, we are done. Thank you all so much. That was fun.